A very good morning, everyone. We will be starting our session for the day. The first session for the day is steatotic liver disease. And for this session, I would like to call on stage our moderators, Dr. Daksh Khurana and Dr. Mark Muthia, to take their seats on the left side of the dais. We would like to call our expert discussants, Dr. Abhijit Chaudhary sir, Dr. Amit Rastogi sir, Dr. SP Singh sir, and Dr. Gaurdas Chaudhary sir, to take their seats on the right side of the dais. The first session lecture is an online lecture by a pre-recorded talk by Dr. Sumit Asrani. He will be speaking on guidance on image-based non-invasive liver disease assessment of hepatic fibrosis and steatosis. We will have the Q&A at the end of the session.
Good morning, and thank you for this kind invitation to talk about imaging-based non-invasive liver disease assessment, or NILDA, of hepatic fibrosis and steatosis. My name is Sumit Asrani, and I'm the Chief of Hepatology and Liver Transplantation in Baylor, Dallas, Fort Worth, Texas. And I'm sorry I could not be there in person as I'm currently traveling. When we think about NILDA and MASLD, I wanted to discuss 4 different aspects. One is the context of imaging-based NILDA. Second is its use at the patient level for assessment of risk of advanced fibrosis. 3 is candidacy for therapeutics as well as response to medical therapy. And finally, its role in cirrhosis and quantifying the risk for progression of cirrhosis to decompensated cirrhosis. When we think about the context of imaging-based NILDA, the things to keep in mind is why use this as compared to serum-based testing? Now, serum-based testing has multiple benefits: repeatable, it's non-invasive, accessible, and it can be combined with other modalities. When we look at AUROC for identification of F4, the performance is not perfect. It's between 0.74 to 0.87. Prior studies have said that the correct classification offered by serum tests is between 35 to 80%. And usually this has high negative predictive value for relevant cutoffs, but it does not always accurately identify patients who do not have advanced fibrosis. There's no single test that is applicable in isolation. And finally, there are obviously issues with intermediate values. With that background, when we think about elastography, I want us to keep in mind that this is not just all FibroScan or vibration-controlled transient elastography. So let me walk you through this. Within elastography, there's strain and shear wave. Within strain, there's displacement by manual compression. And within shear waves, it matters how you generate the waves, either with the piston, which is your vibration-controlled transient elastography, either by acoustic radiation force impulse, and this is your other 2-dimensional shear wave elastography, or with a continuous vibrating source or active driver, which is your MRI or MR elastography. Hence, there's more to this than just a vibration-controlled transient elastography. With regards to steatosis, there are 4 different modalities. There's, of course, ultrasound, there's non-contrast CT, there's CAP, CAP, as well as MRI PDFF. All of these perform and provide objective identification of steatosis. However, the quantification within grades is probably only available through MRI PDFF. Reliability is higher for non-contrast CT and MRI PDFF and not always with CAP. Cost is low for CAP as well as ultrasound and high for MR PDFF. And as of now, currently, MRI PDFF is used in clinical trials. So here, even though there are multiple modalities, each of them have their limitations, one of them being primarily access as well as cost. Within the 3 primary modalities of elastography, what I've shown is the pictures that suggest in columns of minimal fibrosis, advanced fibrosis, and cirrhosis, either through 1-dimensional transient elastography, 2-dimensional shear wave elastography, as well as MR elastography. And approximately about 12 to 15 kilopascals is your cutoff for TE as well as 2D shear wave elastography for cirrhosis, and approximately 5 to 5.5 for MR elastography. The performance, when we look at pool sensitivity and specificity, and let me walk you through this, the dark line is, and the solid line is your sensitivity. Your dotted line is your specificity for these different modalities for F2 to F4, F3 to 4, as well as F4. If we just concentrate on F4, what you can see is all these modalities have pretty much similar sensitivity as well as specificity for identification of cirrhosis, either with one-dimensional, two-dimensional MR elastography. But at the earlier ranges of significant and advanced fibrosis, where the performance is there, it is variable and upwards of 75 to 80%, but not 100%. Hence, that should also be taken into account when interpreting roles of elastography. Pitfalls, keep in mind the pitfalls of drivers of elevated stiffness on elastography. On the left in the table, what you see is certain figures that can be associated with elevated stiffness. This includes getting older, big spleen, steatosis and diabetes, having active hepatitis, elevated ALT, and smoking. So all of these aspects itself can increase stiffness. And on the right, with regards to both steatosis as well as stiffness, as the BMI increases, the prevalence of elevated stiffness is high. So keeping in mind that other things can also increase your stiffness that you see on the recording. With regards to failure rates and unreliable examinations, all these technologies have failure rates, which comes out to about 1 in 20 cases. And associations of things that can increase failure rate include patients who are obese, operator experience, older age, timing of examination, as well as diabetes. Hence, the population where we're using these modalities for itself have multiple limitations that may give us a nuanced result. Having said that, there is, of course, a role of using non-invasive liver disease assessment using imaging-based modalities. The first one I wanted to discuss was identifying the high-risk patient with fibrosis. Now, based on the AASLD guidance in adults with chronic liver disease, imaging-based NILDA should be incorporated into the initial fibrosis staging process because it is more accurate than blood-based NILDA. And in adults with chronic liver disease undergoing initial fibrosis staging, combining blood-based and imaging-based NILDA, especially for the detection of significant fibrosis and advanced fibrosis, is recommended. And let me show you two different approaches in a second. With regards to steatosis also, CAP has good diagnostic accuracy to grade steatosis and can be used in clinical practice. And in adults, imaging-based NILDA with regards to specifically TE-CAP as well as MR-PDFF or MR spectroscopy are superior to blood-based NILDA test and should be used in the assessment of hepatic steatosis where available. Bringing this back into the sequential incorporation of imaging-based NILDA, first, going over the framework proposed by EASL, we looking at patients who have elevated LFTs or risk factors using initial FIB-4, and then subsequently, based on the range of FIB-4, using either an alternate test or vibration controlled transient elastography. For EASL, a cutoff of about 8 kPa is recommended as taking it to the next step of hepatology referral. Hence, again, here what you see is a role of sequential testing. Going over the AASLD ones, first looking at the green bar, what you can see here again is primary assessment is through serum-based, but if the numbers are higher, using secondary assessment with alternate testing, and with regards to imaging-based, again recommending using vibration-controlled transient elastography, of the cutoff being about 8 or so for getting the patients to the next level to subspecialty care. Hence, the number 8 kPa comes across in both modalities. In the other documents, notations for MR elastography has also been suggested, but not currently placed in this presentation. Now, One thing to also keep in mind is that other societies, which is the AHEA, as well as endocrine societies, as well as ADA, have recommended a version of this for patients with type 2 diabetes. So within patients with type 2 diabetes who are at higher risk, the use of FIB4 as well as transient elastography plus or minus MR elastography is recommended. Now, what about for therapeutics? When we think about therapy, what role do non-invasive liver disease assessment tools have in this case? So we'll talk about resmetirom. Now, in patients with MASLD, it is recommended for stage 2 through fibrosis. The clearest indication is patients who have biopsy-proven MASH with F2 to 3 fibrosis. However, what you can also see is a role of imaging-based NILDA is suggested with cutoffs of 8 to 15 kPa for vibration-controlled transient elastography and between 3.1 and 4.4 for MR elastography, and individualized decisions for other modalities. Hence, what you can see here again is this number of 8 to 15 comes into play for treatment for decisions for initial medical therapy. What about for continuation of medical therapy? Again, what you see is guidance of if you started therapy, looking at 1 year and seeing if patients have no response, some response, as well as continued response or beneficial response. And the question becomes is what is a significant improvement in this guidance in improvement of about 25% in transient elastography values or 20% in MR elastography values from baseline are suggested as a baseline response, with minor reductions allowing a benefit uncertain in this case. Responsive therapy will probably be adjudicated more and more by non-invasive liver disease assessment testing. What you can see here is this another study recently published using combination therapy. And what I want you to look at is not the absolute results, but the endpoints that were used. In this case, it was proportion of subjects with normalization of liver fat by imaging, as well as percent change from baseline in liver stiffness on mean changes as compared to placebo. Actually, more and more NILDA may play a role with regards to therapy as well as response to therapy. And finally, what about risk for progression in patients with cirrhosis? We're familiar with using a version of combining platelets, LOS, as well as liver stiffness measurement versus MR elastography to identify patients who may require further surveillance for decompensation. So cutoffs, here what you see is sort of 25 and above is suggested as clinically significant portal hypertension for clinical management. In addition, these values can also assist in identifying patients with future decompensation. The question becomes, if these are all retrospective studies. On the left, you see a combination of MR elastography with higher values associated with future decompensation. And on the right, higher values of liver stiffness above 21, also associated with higher evidence of progression. But putting it all together with regards to portal hypertension, yes, combination is suggested to assess for presence of clinically significant portal hypertension, but it cannot reliably be used to quantify higher degrees of portal hypertension. Third, serial measurements can be used to monitor progression in patients who don't have baseline clinically significant portal hypertension. However, in patients that receive treatment, which is point number 4, it's unclear if the stiffness measurement tracks directly with longitudinal changes in portal hypertension. And finally, in patients who have clinical significant portal hypertension, there's insufficient evidence to support the use of all these modalities for every single patient to predict clinical outcomes. So in summary, imaging-based NILDA as combination or sequential testing in the general population plays a role. Imaging-based NILDA will have an increasing role in medical therapeutics. The active issues remain with regards to cost, access, overestimation, and unreliable testing. And the active issues continue to be there with regards to inter-observer reliability with serial measurements and quantification of true improvement. Thank you again for your time, and I'm sorry I cannot be there for the Q&A questions, but please feel free to contact me for any concerns that you may have. Thanks.
Okay, thank you. Thank you, sir. Now, moving on to our clinical case discussion on obese MASH with comorbidities, I would like to call our case moderator, Dr. Swapnil, panelists, Dr. Pathik Parekh, Dr. Manish Manrai, Dr. Abhideep Chaudhary, and Dr. Madhumita Premkumar.
A very good morning. So in the next 20 minutes or so, we will be discussing how we manage comorbidities in patients who are having MASLD with obesity, with cirrhosis, and how do we take up them for transplantation if a transplant is being contemplated. So these are the comorbidities which I thought we would like to be discussed and are of importance, like diabetes mellitus, renal dysfunction, obesity, coronary artery disease. How do you advise a nutritional and exercise prescription? And what are the challenges in taking these patients for transplantation? So I think it would be a very short and brief presentation and with very short questions and answers. So I think we'll start with a short case, and so that we get an idea of the comorbidity, like we get an idea of how sick patients we are seeing on a day-to-day basis, and how it is very difficult to take them to liver transplantation. So she's a 67-year-old female with comorbidities, diabetes, hypertension, hypothyroid, and obesity, diagnosed as MASLD-related cirrhosis 6 months ago, and presented to us with complaints of increased abdominal distension, decreased urine output, and had ascites and bilateral basal effusion. These were her evaluation. Her INR is of 1.57. Creatinine when she came was of 2.3. Which subsequently, at the time, after 4 to 5 days, improved to 1.6. Her bilirubin is 2.5, albumin of 2.7. So she's a CTP9B cirrhosis with mild sodium of 23. She has a poor performance status. She's sort of bedridden because of her weight, and she had some proximal muscle weakness, so a KPS score of 70. She has CSPH, underwent EVL for high-risk varices. And these are the images. Can I have a pointer here? So these are the images of the MR, which show the cirrhotic liver with ascites. And if we measure her, we didn't measure her L3-SMI over here, but if we can see the psoas muscle thickness, it was 13 mm, and psoas muscle to height was 9.48 mm. So it's a decompensated MASH cirrhosis with CHPH, has ascites, has acute on chronic liver disease, chronic kidney disease with a baseline creatinine of 1.6. She has a UTI. The culture showed E. coli along with her comorbidities. So my question to the audience, so what will you be able to do for such patients? Long-term advice, that considering her comorbidities, you advise only a standard medical care treatment with supportive care. You want to add on nutritional rehabilitation for her. You will advise liver transplantation in the long term, or in view of significant underlying renal dysfunction, you will advise a CLKT or SLKT, or you will advise a bariatric intervention, and if she reduces weight, and then only consider a liver transplant. The voting pads are there at the table. So majority of us want to continue standard medical treatment along with nutritional rehabilitation that probably includes reducing down the weight and building up the muscles. So none of us is probably willing to take her as in this current state for a liver transplantation. So this is what we did. She stabilized, we discharged her. She again got admitted 4 weeks later with again decreased urine output, breathlessness, altered sensorium, hepatic encephalopathy grade 3. She required ICU care, inotropic support, and CRRT for a while. Subsequently, she started pouring in. She's now stable and shifted to ward. So we also probably offer of the same opinion that she's too sick to be considered for transplant. So let's come down to the discussion of individual parameters like comorbidities. So my first question is to Dr. Madhumita ma'am. So how do you manage diabetes in patients who have decompensated MASH cirrhosis? and what is the role of newer agents?
So this patient is a tough case, but it is a standard case because she has CKD as well, she has decompensated, she's having diabetes, hypertension, may have heart failure because she went into a pulmonary edema, required dialysis. So here the kind of drugs would be very limited. She has had a UTI, so SGLT2 inhibitors like Empagli, which would be great otherwise because it mobilizes the situs. That's out because UTI and CKD, EGFR is low. So here one would have to give insulin possibly. Linagliptin is the only drug that can be given out of the newer OHAs, and maybe some amount of metformin. Later on maybe one can consider adding Empagli because that has got survival benefit in patients with heart failure with preserved ejection fraction. But as of now, none of the GLP-1 analogs and all can be given.
So in decompensated cirrhosis, only insulin is the option, right? Moving on, we will discuss the renal dysfunction. So my question to Dr. Manish Mandra, what are the phenotypes of renal dysfunction in patients with cirrhosis and how do we manage them?
Now the recent consensus which has come last year, they have made HRS-AKI as a subset of HRS-AKD. So now we have HRS-AKD in where the duration of renal dysfunction is less than 3 months, or HRS-AKD when it is more than 3 months, and HRS-AKI is a subset of it. They have started introducing this concept that there is some amount of reversibility because of HRS-AKI in almost all phenotypes. In addition, they have mentioned that there is no mandatory requirement of giving albumin for 48 hours. You just research for 24 hours. All this is probably being revised so as to we can introduce terlipressin at an earlier stage and we need not chase albumin decreasing the creatinine level. The standard management for HRS-AKI would be use of terlipressin and albumin. And HRS-AKD, if the creatinine goes more than 4, then probably CRRT will obviously be required. Some form of renal replacement therapy will be required.
Agree. So, and depending upon the response to therapy, how would you like to plan the long-term management? Like suppose this patient responds like from, there is a significant regression of AKI or vis-a-vis there is no improvement in AKI.
So there is no improvement of AKI and the patient already has underlying diabetes, DKD going on to CKD. That will be a time where we'll have to consider, especially if she loses weight and becomes slightly fit overall for transplantation, then we might have to consider a simultaneous liver kidney transplant.
So the next question to Dr. Pratik Parekh. So how do we decide regarding a liver transplantation alone versus a simultaneous liver and kidney transplantation in such sick patients who have renal dysfunction?
I think
considering that if at all you want to, like these patients when they develop renal dysfunction, they behave like ACLF. And if the two most important predictors of mortality in patients with ACLF, the one is infection and the second is renal replacement, need of renal replacement therapy. So you need to choose your patients wisely to have a good post-transplant outcome. So how do we choose them?
so. The guidelines are very clear onto it that if it's definitely this patient has a diabetic obesity, there is more chances of diabetic nephropathy in these patients, and there is going to be a CKD. But if there is more than 3 months with an EGFR of 30, less than 30, then they would be considered for an SLKT. Or if there is an acute kidney injury which is persistent over a period of 6 weeks or more with a weekly creatinine, if we are measuring weekly RFT and GFR remains less than 25, or there is a need of dialysis, then they would be considered for an SLKT. However, otherwise they would, the recommendation would be to consider for a liver transplant alone, and considering KLT or kidney after liver transplant in patients who continue to deteriorate 2 months beyond or requires a renal replacement therapy 2 months after the liver transplant.
So as we speak, I mean like so she got admitted 4 weeks later with worsening renal functions, and if at all she is fit enough to undergo a transplant, then it has to be an SLKT. But in the hindsight, 4 weeks before, if like she would have been sort of further optimized and renal functions were same and the surgeons were on the same page that she can be operated. So would anyone from the panel, maybe Dr. Abhidip, would have advised a liver transplant alone at a creatinine of 1.6, EGFR of more than 30?
So other than the creatinine, I would want to look at whether the urine output is okay or not, whether there is acidosis or not. So just looking at creatinine alone would not make me decide to go for simultaneous. So if someone is non-oliguric, does not have acidosis, I mean, these are the patients who can be considered for liver alone.
So the weight and the obesity and performance status are not the...
No. So
yeah.
if the patient is optimized,
Yeah.
required a temporary CRRT, that's fine. But then again, the creatinine bounce back to 1.6, 1.7, or even up to 2. And the patient is making good urine, and and the general condition is optimized, then liver alone would be considered.
So then the most important thing is you need to optimize the patient, bring the weight down probably. Everybody agrees that the patient needs weight reduction, or yeah. So I think we'll just discuss the obesity part. So what are the pharmacotherapeutic and endobariatric options, if at all any, which can be done in patients with MASL? And in the given context, patient, can we use any of them? Dr. Pratik sir.
In a decompensated cirrhotic like this, I don't think that we have enough, obviously bariatric surgeries are out for a decompensated patients, but for the drugs also, we do not have data of anything other than orlistat to be given in a decompensated cirrhotic patient. With tirzepatide now going to be available in India, I think there would be good data where people would be using it beyond compensated cirrhosis in early decompensated cirrhosis, and we would see how it benefits. As of now, not for any decompensated.
So any role of endobariatrics in cirrhosis, not in the decompensated like her, but maybe compensated cirrhosis?
In a compensated cirrhosis where we rule out as clinically significant portal hypertension, then endoscopic sleeve gastrectomy or even a laparoscopic sleeve gastrectomy or an intragastric balloon would be considered in this patient.
So, and because this would have a holistic effect, they will try to act on the aspects of MASLD, dyslipidemia, blood pressure, obesity. So I think in compensated cirrhotic patients, putting an intragastric balloon is a good idea. This is what our experience, in which we have done in patients who had child A and child B cirrhosis and subsequently bridged them for transplantation. However, these are not at present the current guidelines of treatment, and use of endobariatric therapy in cirrhosis is not a current part of guidelines. So coming to the next comorbidities, the coronary artery disease. It's a significant important factor of morbidity in patients with obese MASH, and that can vary from cardiac involvements to pulmonary involvements, which could be from coronary artery disease, cirrhotic cardiomyopathy, HPS, POPH, and anything. And it's a very important cause of mortality after liver transplantation, both early mortality within 30 days. So if we compare the mortality due to CVD after LT, it's almost 1.2%, as compared to mortality related to CVD. In CABG again it is 1.7%. So it's almost equal to CVD mortality after CABG in the first 30 days. If we see the long-term mortality, that is again a major cause of non-hepatic cause of mortality in the long-term liver transplant recipient. So it's a major factor which is largely preventable, and that is why if at all a transplant is being contemplated, you need to choose your patients very wisely. So my next question is to Dr. Abhideep Chaudhary sir. So how do you predict the likelihood of underlying CAD or an obstructive CAD in a patient who is being planned for liver transplantation?
So first and foremost, these NASH patients or MASH patients, they have a higher chance of cardiac coronary disease. And plus, if they have more risk factors, like they've been smoking or there is significant diabetes, hypertension, they become pretty high risk. So these patients need to be evaluated further on terms of detecting coronary artery disease, either by doing a calcium score or CT angio or a conventional angio. Now, as per American Heart Association guidelines, more than 70% stenosis, these patients should be treated with bare metal stent before going for transplant, but then this varies from center to center and country to country, not all patients, because there is data on that as well, that asymptomatic patients who were treated beforehand and not treated, it does not change the overall mortality post-transplant.
So this is the protocol given by the LTSI for cardiac evaluation of patients who are being planned for liver transplantation. If the DSC or the CT coronary angio score are higher, then the likelihood of underlying obstructive CAD is high, and then you do an invasive coronary angiogram. Otherwise, you can proceed with the non-invasive evaluation. And as Sir had said that depending upon the extent of disease, the further interventions can be planned. So my question to Dr. Manish Mandra, how do you manage who have proven obstructive CAD and being planned for a transplant?
So in this case, we have to analyze that how much is the time given to us prior to liver transplantation by a patient having obstructive CAD. The second point will be what all vessels are involved in CAD, whether it is a left main, left anterior descending, which are the two major vessels which need revascularization. The third thing, if we have time, the patient can be subjected to a PCI And third generation drug-eluting stents, that is everolimus, otariolimus, they actually require a lower DAPT time. So you can actually use DES, optimize the cardiac function, and at the same time, you can consider them taking up for transplant in maybe 4 to 6 weeks. If there is urgency to transplant and there is high risk of bleeding, oblique coagulopathy, then cangrelor is an intravenous P2, PY212 inhibitor, which can be used. Ecosprin can be continued, clopidogrel can be stopped, and this can be used during the perioperative and intraoperative period to minimize the risk of stent thrombosis, at the same time achieving the objective of carrying out a liver transplantation. The third thing is CABG, which has been discussed yesterday by Dr. Prashant also. It is difficult.
Our paper of around 10 patients in whom we have.
And one thing
patients.
which was mentioned, drug-eluting balloon. Angioplasty can be used because that shortens the duration of DAPT.
So that is used in patients who probably have sort of thin plaques and have a good performance status and younger age as compared to the other.
Yes, yes.
So I think everybody of us agreed that this patient needs nutritional rehabilitation, and as we discussed, the muscle evaluation or the sarcopenia part needs to be addressed, and we usually assess this by doing an L3 SMI, and the cutoffs given by the European group are less than 50 centimeters square for males and less than 39. However, I think since the cutoffs for BMI are different for Western population versus the Indian population, I think we have to have specific cutoffs for Indian population, and there is data from North India. We have suggested almost 10 lower cutoffs in male and female. So my next question is to Dr. Madhumitram. So I think everybody in the house agreed that this patient needs nutritional rehabilitation, and that probably includes losing weight and improving the muscle. So how do you advise weight reduction? If yes, you advise, what is your prescription for nutritional rehabilitation and exercise in such patients?
So this patient came with critical illness, was on CRRT, so we will not advise a reducing diet.
In the first admission.
In the first admission.
Yeah.
So the second admission, now she's again come unwell. So we would not advise a very restricted diet here. We would have to give a good amount of protein. What one has to do is start mobilizing. Her performance statement was very poor. So she needs to be mobilized out of bed. She needs to be doing a combination of resistance and strength training. And her dry body weight has to be taken into account because this patient had ascites. So we need to actually calculate what her dry body weight is, and the nutritional requirement should be calculated on basis of her dry body weight and her ideal body weight. And it will take a long time for this patient to be improved or optimized for transplant. So here this is a case of sarcopenic obesity.
Yeah.
So here we will not be restricting too much. Maybe the ratio of protein, calorie and fats will be changed. BCA has no real role, especially in critical illness, but if it is added with graded exercise, maybe that might help here.
This is what we follow in Medanta. The focus is on weight management and metabolic improvements. I'm discussing in the first admission. Obviously, we didn't choose to transplant and subsequently see required ICU care. At this point of time, we can't really go with a very intensive rehabilitation, but this is what we usually follow. So when such patients are considered for transplantation, then obviously the main factors which are hindering the transplant are renal dysfunction and CAD, which we have discussed. How do we manage them? The next question comes regarding giving such obese patients an adequate volume of graft. So my next question is to Dr. Abhideep Chaudhary, sir. So what are the difficulties do you face in subjecting these patients for liver transplantation?
So regarding these patients, first and foremost, we cannot go for the ideal kind of GRWR, and which is now being debated as well, that there is no ideal GRWR, which earlier we used to think that 0.8 or 1 used to be ideal. And then the fat component does not have significant metabolic requirement. So if we somehow can find out an ideal requirement of the liver for a particular muscle mass, that is something we don't have. But then looking at the data, people doing transplants with GRWR even less than 0.6, I think most important thing is giving an adequate liver mass, which in various studies have been shown 650, 700 grams of liver, and a GRWR of 0.6 with optimized portal flow to these grafts are the most important thing. So if you have to do a portal flow inflow modification by either doing splenic artery ligation or shunts, those are more important thing than to look for a graft which is
So you are more in favor of a graft mass rather than a GRWR?
Sorry?
You are more in favor of a actual graft mass rather
Yes,
than a GRWR?
that's correct.
Okay.
Graft mass as well as the portal hemodynamics.
Yeah. And whenever we are going with a low graft mass or a low GRWR, then you need to go for an
Portal inflow modulations.
So apart from that, there are other, what are the other ways of like managing such patients?
Yeah, so dual lobe transplant is another thing which can be considered if you are unable to get even 0.6 GRWR as well. So the graft mass is less than 600 or 650 grams, and those situations we can consider dual lobe as well. But mind you, dual lobe increases the overall surgical extent as well as surgical time and put the patient on slightly higher risk in terms of outcome. So if possible, try to do it with a single lobe and with optimized portal inflow.
Okay, okay. So just to conclude, patients with MASH often have multiple comorbidities, and we need a holistic approach which include weight reduction and management of their comorbidities, which needs individualized. Renal dysfunction and CAD often have a negative impact, and we need to resolve, identify the phenotype of AKI, manage it, and subsequently decide what the patient needs, liver transplant alone or a combined liver and kidney transplant. The risk of cardiovascular disease or obstructive CAD needs to be evaluated taking into account the number of risk factors and the likelihood of CAD, and the interventions are based on the extent of stenosis and the severity of liver disease. LT in an obese mass is always challenging, and we need to give a good graft mass or volume to prevent small for size or the early allograft dysfunction, and there are various strategies to overcome that. As the patients have multiple comorbidities, management of such patients often need a multidisciplinary metabolic care, which we follow in Medanta. Thank you. I think the house is open for discussion, and
the house is open for questions, and we would like specifically our senior experts to comment on the case or the talk by Dr. Subita Saraf.
A provocative question in the morning. What happened to this patient?
so this patient is still admitted with us. It's like she admitted 10 days ago, requiring ICU care, now shifted to ward.
Fair enough. 10 days is still pretty short. But I'll ask my question to Neeraj. You know, when you get a patient of this background, how many of them, in spite of all that you do, ever become good enough to go in for a transplant? And if at all they do, how many of them actually make it? Any honest answers?
So very few of them do make it, and that is what we have seen in our case, that we decided to manage them medically, and obviously she again came with a worsening clinical conditions. So it's very difficult, very challenging to manage such patients. We are left with only standard medical treatment, and with that the outcomes are not really good.
The other thing is, I thought that, you know, I didn't see the word frailty in your discussion. I think that many people are now moving from sarcopenia to assessing frailty, because that gives a better outcome post-transplant, I believe. So your thoughts on that?
Yeah, definitely, sir. Frailty is an important aspect of functional muscle component, and the assessment is a bit difficult in patients requiring ICU care. So I think the liver frailty index and all have shown that it's definitely better. And what we have shown that a combination of L3-SMI plus frailty predicts survival of such patients without transplantation or after transplantation in a better way rather than these components alone. Yeah, sir, please.
Morning. My question actually is to Dr. Abhidi. So you mentioned absolute liver mass for the patients, which was corrected for body fat because that doesn't have a metabolic requirement. But that's not the only sort of driver of the requirement of liver, because on the one hand you have an obese patient with fat, but you also have an ACLF-like situation, acute decompensation situation, which probably requires a higher metabolic mass of liver to compensate. And so how would you actually correct for that difference? Because I know there's no right answer for this, but once you have sort of several competing factors, one is frailty, one is obesity, one is ACLF, the patient's condition. So what is your formula for deciding what is an adequate GRWR? Because certainly if you have a 110 kilo patient who has ACLF 3, 650 grams is not going to cut it. You will probably require a little bit more. The question is how much more?
So what in my mind is adequate portal flow is the most important thing. So when we look at this, we look at the size of the spleen. the portal pressures, the portal flow, the hepatic artery to splenic artery diameters. I think going into more technical things, I would want to look at these things and deciding what would be the ideal situation to do a procedure, portal inflow modulation in these kind of situations. So I think a basic adequate mass, which should provide adequate liver mass to regenerate, plus an optimized portal flow, a combination of that would be considered rather than anything alone.
And the second point, I mean, I don't think we should be talking about dual lobe for this kind of patient at all. Because it's just not making sense. The risk benefit would not, a patient who is this sick, who's bedridden, who probably won't survive one transplant, let alone two. I don't think that, I understand for complete.
So we didn't take the case along the whole comorbidities. The case was just to start off the discussion, and considering the comorbidities which we see in such patients, when these patients, not this particular patient, but a patient who has with an obese MASH and we have a low GRWR. So what are the strategies to optimize those patients? That was the purpose of discussing it, not in the given context.
This patient, we are not even sure will reach to the transplant. Leave again.
Definitely. She has not reached, we never contemplated transplant for her in the first place also.
Okay. The thing is that one must understand that if you look at it from the holistic point of view, the idea is to obviously save the patient, right? And this patient is going to need a transplant unless, if you want to save this patient, eventually this patient has to have a transplant. Now, how to get her ideally prepared for transplant? What you can treat is sepsis, you can control diabetes, you can stabilize renal dysfunction. Actually, getting her nutritionally okay is a pipe dream in my view. Getting sarcopenia sorted out, nutrition sorted out is, like you said, is going to take a very long time. It may not be a guarantee in most of the patients, right? Is there evidence that sarcopenia and nutrition actually get better in these patients and over how much time? That's one question, but most of my comment here is just an overall view. So I think these patients should be stabilized as best as they can. And then you proceed for a transplant. If no infection, if the renal dysfunction is controlled, this patient should not have a simultaneous liver kidney transplant. They should be ideally prepared for a liver alone. But if the decompensation settles to such an extent that this patient stabilizes over months, then it's a different matter. Then you assess at that point on the merits of the case. So right now, control diabetes, control infection, get the renal dysfunction better as much as possible, and then you consider this patient for a transplant if the performance status improves. As far as the GRWR is concerned, I'm quite clear that before the surgery, you have to optimize the conditions. So if you actually go in with a 0.6 GRWR and you land up with a 0.5 at surgery, that's not a very happy situation in a sick patient. So I would, if the patient was stable, get an ideal GRWR, and the patient is not stable and there's only one donor with 0.6, 0.65, I would not proceed for a liver transplant.
Dr. Amit, do you have any comments on, anything you...
Just one second. What about the evidence for controlling sarcopenia and nutrition in these patients?
So, not in the given context, but if these patients, if there is a delta improvement in the LFI or delta improvement in the SMI, then the outcomes without transplant or after transplantation are better if we assess them dynamically over a period of time. And the delta LFI, the liver frailty index improves. If we are able to improve that and see that, then the outcomes are definitely better.
Yeah, but what proportion of patients are you able to improve?
Not more than 30 to 35.
30%?
So there's no evidence. There's no evidence
So
that
I don't
improvement in
think there's any
sarcopenias.
evidence.
No,
Yes,
there isn't. You're absolutely right.
Yeah.
But there are studies of delta LFI change and all, and which have
But
shown.
no,
that is correct.
nothing to improving survival, nothing improving their likelihood of getting transplantation. It is all a hypothesis. We know that sarcopenia is going to have adverse outcomes. We assume that improvement of it is going to translate into better transplant outcomes. That is not the case. There is no evidence to suggest it.
Okay.
So in this patient, getting a splenic volume can also give a clue that because portal flow also depends on splenic vein flow, and if spleen is too large, there must be a lot of flow, And before that, we can, if the spleen to graft volume ratio is higher, we can go for splenectomy, give the patient vaccinations before planning the surgery, and can proceed.
So, Dr. Abhidip, do you go for GSPR and
So as I just mentioned about this, these are something, the spleen volumes, splenic artery to CHA ratios, portal pressures, portal volume, these are all standard things that I think most of the centers doing LDLT would consider.
So most of the things have already been discussed. I agree with most of them. One or two places where I would have a different opinion. This patient obviously is a sick patient. One, this patient apart from liver has other problems, that is a major problem. This patient does not have a kidney disease. So by criteria, thinking of combined kidney liver probably will not fit in this patient. We improve this patient, take it to a fair enough risk. You cannot completely become like a normal CLD patient. So it has to reach a fair enough point. Once it reaches a fair enough point, then you have to decide whether to do transplant or is it too risky. The other question is, once you do transplant, then the technical issues of how it can be done and what it can't be done. And then the other issue is, once all this is done, then again the post-op recovery is not easy for such patients apart from liver regions. All the things we have discussed, we take it to surgery. So my point is, probably liver alone would be needed. Kidney probably won't be needed because 2.6 come down to 1.6. Again, so all these are acute events and probably there is no kidney disease. You take it to liver, then the discussion is on, obviously such a patient, you can't reduce weight and you have to take at whatever BMI. The BMI is high, so you will have to probably, ideally is one donor. I probably do not agree with the concept of absolute liver volume. 650 is not the golden rule, or 700 is not the golden rule. If you have the study where you have two groups where more than 100, see if you take 650 or 700 as a GRWR, probably you are covering 85 or 90% of your patients either way. So then your results would be good and you say this is the gold standard. You should have two groups beyond 100, one you give 650 and another one you give the standard 0.8 or something, and still if you say it is equal, then 650 is the rule. So this impression of giving adequate liver to a patient who is irrespective of weight is probably not a good idea. I would not shy away with dual lobe in such a situation, because what else would you do? So you've optimized the patient, you've reached to a point where fair enough risk is there. Now you have two options. You do transplant or you don't do transplant. If you do transplant, dual lobe for a recipient is not such a adverse thing. You have two donors. You can do simultaneous or you can make it into one liver. What I'm saying is, you have a choice of giving 0.6 GRWR versus a dual lobe with a fair enough 1 gram GRWR. The recovery is possible, recovery is better. So this concept of not doing a dual lobe in such a situation, I would not completely negate it. So these are 2-3 things which I...
Okay, so let's keep transplant aside. My question to Dr. Chaudhary and Dr. SP Singh. So how would have medically optimized this patient in a better way in the first admission? I mean, any suggestions or any inputs from both of you?
Swapnil, sorry, my voice is very bad. Swapnil and I think Dr. Soin both. In case you are able to optimize, just, barely optimize for liver transplantation, would you then, I mean, kidney doesn't arise here, would you in addition to that like to do a sleeve gastrectomy with the procedure?
So we have not done simultaneous, sir.
Because there is some evidence, I think, in literature where they have a good, reasonable success.
So, two things. One is, like I said, I would not transplant this patient with a low GRWR once she's fit for transplant. I would either not do it or do a dual lobe. And in our experience and view, dual lobe transplantation has no extra risk for the recipient. All you're doing is spending an extra hour doing the second implant. That's it. So for the recipient, it doesn't make that much of a difference. And we've seen this in our own series. So I would do a dual lobe or not at all if the GRWR is not right. The second thing is the debate of actually doing a bariatric procedure before, during or after surgery. That's an ongoing debate. DDLT series in US have actually shown that intra-op bariatric procedure works quite well. But my view is that intra-bariatric procedure is not actually needed for the recovery of the patient. So once the patient actually recovers from a transplant, then they are in a fitter position to undergo a bariatric procedure should they need it.
Thank you, sir. Now I would like to call all the doctors involved in the session to kindly come forward for a photograph.
Hello. So our next session is keynote lectures. I would like to invite our moderators, Dr. Rajat Shukla and Dr. Monica Jain. Chairpersons for this session are Dr. Vikas Deswal, Dr. Akash, Dr. Mandir Kumar, Dr. Karthik Mathivanan, and Dr. John Menaki.
So the first talk is an online talk by Dr. Punita Tandon, and she'll be speaking on integrating lifestyle and health practices in managing chronic liver disease. And she's with us live, so she'll take questions after the talk.
Thank you so much for the opportunity to present today. I really am thrilled about this conference, and so sad that I couldn't be there with you. This is exactly what I think we need, the holistic management of liver disease. So very excited to talk to you today. I am presenting with my hat, of course, as a transplant hepatologist and director of our Cirrhosis Care Clinic, but also really thrilled to be able to present to you as a certified wellness coach and a certified breathwork and yoga instructor with my yoga instructor training from Rishikesh. So let's talk a little bit in the next 15 minutes about why a whole person, holistic, integrated care approach is important in chronic liver disease, and then some steps as to how we can move closer towards this. We know that well-being has many components. We know that in our clinics, we often put most of our focus, I would say 95% of it, on physical well-being, and in particular on liver health. And this is appropriate, we're trained as hepatologists, but we need to understand that well-being and holistic health go well beyond physical to psychological, social, occupational, financial, and even physical health expands obviously in our patients, very importantly, to things like muscle, which I think you will have heard very much about during this meeting. Why is this important, this holistic approach? Well, physically and physiologically, our patients are actually geriatric. This is a systematic review of 7 studies in over 1,100 patients where they looked at VO2 testing. And you can see the mean biological age of our patients in these studies, 55 years old. When you put them on a VO2 bike or treadmill, the mean physiologic age, their body age, is 85. So 30 years older. And not surprisingly, many of our patients have sarcopenia. Many of them are frail. And it's not only just the physical, it's also the mental, emotional symptoms that they have. So when we look at this, we see that these patients have symptoms that are on par with advanced malignancy. When you ask them what their quality of life scores are, they're low. This is across multiple studies. We're looking at in the 50s to 60s out of 100. Lots of stresses, lots of uncertainty, lots of family worries, social stigma, financial distress. And this graphic just shows you across Child-Pugh A in yellow and Child-Pugh B or C in orange, the high proportions of patients with symptoms. Do we even ask about these? Do we even know they're there? So in the ideal situation, I'm saying ideal, what can we aim for as a community? I think the ideal situation would be to screen all patients, every single one who's coming in with cirrhosis, to identify what are their broader health needs. And you could use tools like malnutrition screening and frailty screening. You could use symptom assessment scales like the Edmonton Symptom Assessment Scale. And then we could use that information, again in the ideal situation, to provide tailored support. And tailored support ideally by a multidisciplinary team. That team could include individuals such as palliative care, people doing mind-body therapies, which we'll talk about, addiction support, nutrition, social work, exercise, nursing, geriatrics. Okay. I don't have access to a clinic like this. I'm sure many of you also don't. But I think this is obviously something that in an ideal situation we can even start to move towards, perhaps a clinic that just even has nursing as part of it in addition to nutrition. That's what our current clinic is. Perhaps other combinations of these. Because we know that these multidisciplinary clinics work, and there's been a lot actually written now in the literature about even how to set them up and why they are very valuable. But as we work towards that, what other small steps can we all take in order to promote holistic care in our patients? Now, I'm going to go through three big things. And you know, if you know me, you know this is number one. So nutrition. You've heard about this probably during this conference. And I will just say that I think that Indian hepatologists are doing excellent at leading the way in this. I have seen multiple patients who have been referred to me because they've moved to Canada or other things that have been seen by many of my colleagues in India, and all of them have heard about nutrition. So ask about it, continue to ask about it, involve your dietitians because we know this improves outcomes. So we're talking about assessing dietary intake, what are the barriers to intake, asking about whether they can afford food, giving them educational information using handouts. Food is medicine, and we know, I think you probably have had this covered, but we're talking about calories, adequate amount of protein, adequate timing of nutrition intake, so breaking the fasting period, and those things improving muscle mass, quality of life, encephalopathy, as well as readmissions. And again, you guys are leading the work in some of these interventional studies. This is a beautiful study by Dr. Taneja's group, 100 patients, 60% with alcohol use disorder, randomized to usual care versus a dietitian getting involved. And what happened? Significant improvements in protein intake, significant improvements in frailty, and in the skeletal muscle index, and in hospitalizations. This is another recent study looking at very severe patients, so people with subjective global assessment C and low hand grip strength, and they were randomized to nocturnal NG feeding with dietary counseling versus just dietary counseling alone. Average duration of the intervention was 2 months. They found significant improvements in hand grip strength, protein intake, mid-arm muscle circumference, calorie intake, and immune function measured by quantiferon. They did have tube-related complications, but very few of their patients had to discontinue because of this. Okay, nutrition, absolutely important. I think you guys are doing great with this. Continue to do that. Exercise. I think there's still room to move here. Talk to your patients about the importance of physical activity. If you don't have exercises available to you, send them the information if they speak English on cirrhosiscare.ca. I'll show you just one exercise study. There have been now multiple, over a dozen, showing improvements This is one of my favorite studies of the ones that we've done, and it was the first randomized controlled trial in exercise, now 2014, that was of a substantial size, 19 patients. Again, I'm coming back to that physiological age concept, really cool. These guys, when you got them on the exercise bike to measure their VO2, they were 80 years old in their body when they started physiologically, 8 weeks of being on the bike, 2 to 3 times a week. They got 13 years back in their life. So bodies felt like they were 13 years younger, and not surprisingly, they had less fatigue. Okay, so this is, I tell my patients this. I tell them that they can feel it and be younger with exercise. Now, thirdly, I want to touch on something that I think is the future of how we deliver holistic interventions in chronic liver disease, and this has been the focus of my research over the last 5 years, and it's digital solutions. And some of you are going to say, oh, our patients don't necessarily all have access, and I totally agree. Our patients don't all have access, but I think this is changing, and it's changing rapidly. This is some data from that I got from the internet, just looking at the share of Indians using mobile phones by income quintile. You can see even in the poorest group, women having less access than men, but even in the lowest income group and in women, 67% have access to a mobile phone, okay? This is only going to get more and more prevalent. We need to embrace digital solutions. How can we start? We can deliver education. All patients deserve information. There is a lot of information available on cirrhosiscare.ca. I'll show you this short video for those of you who aren't familiar. For your patients who speak English, this is excellent. There's also, as you can see at the top, a checker that you can change to different languages. You can click here to print handouts. These are currently available in English. I will work with anyone to get these translated though, so please reach out to me if you're interested in that, and you can print, again, any of these handouts for your patients. You can also use this same site, this homepage, to email educational resources. If your patients speak English, this is a no-brainer. Put in their email address in this line, and then you can select for them whatever resources are relevant. So here, a video about ablation for HCC or diuretics or hepatic encephalopathy. And of course, I always send videos of nutrition information and then submit it. And to their inbox, they get an email saying that their team has sent them information. Okay, easy, easy. Something that, again, definitely I think could be adapted to the Indian context. And I want to end with a topic that I haven't spoken much about in the past, which is another real passion of mine, which is mental health therapies. And I think that is a huge part of our holistic approach in chronic liver disease. And we've designed several versions of an online digital application, which has supported over 2,000 individuals, range of ages, range of technology proficiency. We're currently running 2 larger studies with this. One is a study of prehabilitation or nutrition and exercise support prior to transplantation. This is Chris, my PhD on this project. We've got 5 participating liver transplant centers, and all of them are using this app to give their patients nutrition and exercise support. I won't talk too much about this study, but happy to answer some questions about it if there are any. I want to focus more on the mental health piece, and this has been a real passion of mine. So as an Indian and a Canadian, so a Canadian of Indian origin, I have loved bringing together the East and the West, or the best of the East, the best of the West, as I call it, for mental health support. So the East, things that we bring: Tai Chi, yoga, breath work, meditation. Things from the West: psychology, I think exercises, and bringing those together into one intervention, which is delivered digitally, has been the focus of some of my recent research. And so we're combining these things, combining disease education and some community support. And these studies actually, I started in inflammatory bowel disease, where we did randomized controlled trials there. I progressed into 3 studies in primary biliary cholangitis. I'll show you the data from one of those. And then I'll also show you our most recent study, which is the EMPOWER study, which is just completed. So this is one of the published PBC studies, 87 participants, 60 years of age, and 98% female, of course, with PBC as the disease. Significant improvements in mental health with the intervention, which is this online mind-body wellness intervention, and even greater improvements if the person did the programming more often. We've just, as I said, finished up this large study of 825 adults. I was interested in seeing what if we put a bunch of different chronic conditions together and supported people. And in this, we had 3 arms. One was a control group, one was the online program, and one was the online program with a little extra support from individuals that were non-psychologists, so just students who would call the participants once a week to check in, 12-week intervention. 31% of the individuals had chronic liver disease, predominantly PBC. 825 participants randomized. They were 55 years of age as an average, majority female, majority white, majority frail by the Edmonton Frail Scale. And the majority had had no prior experience with meditation or with yoga. What did we find? This is just being submitted for publication. So this is pre-publication results. But what we found was pretty impressive, I think, in this large group. Depression scores improved by 32%, anxiety scores 17%, and very interestingly, fatigue improved by almost 20%. And this was across different domains: physical, central fatigue, and psychosocial fatigue. This study we're following up. Actually, we're just recruiting now for a study looking at the mechanisms of this, and we've been doing functional MRI scans, which are very interesting, as well as some enhanced objective fatigue measures. So a lot of my work also includes getting participant feedback in addition to surveys, and I think this is something that I would love to see us doing more in India. But some comments like, a study that encompassed the whole person instead of just looking at the disease as a physical thing. Never thought I could feel this good. Makes me a nicer person, more energy, less emotional, better sleep, changed my life. So really powerful kind of feedback, which comes with providing holistic care. So in summary, I think I am totally bought in. We all need to move closer to whole person care for our patients with chronic liver disease. As I normally do, I would ask you to think about one small change from what I've talked about that you can apply in your practice for next week. Can you start talking to your patients more about the importance of nutrition and exercise? Can you prescribe cirrhosis education materials? Reach out to me and help me to translate the videos that we have on cirrhosis care so they can be more useful to an Indian population. Wow, we are in India the birthplace of a lot of these mind-body interventions. They are powerful and they can improve things like mental health, fatigue, multiple symptoms. Please encourage them. And most importantly, also, please continue to lead the high-quality research that you're doing in whole person care in India. I would love to work with, anyone who's very interested in this space. Thank you very much for your time. Looking forward to your questions.
As Dr. Punita is online, we will have a Q&A for her lecture right away, and subsequently at the end of the session.
Is it audible? Professor Tandon, that's an excellent talk. My question to you would be regarding the improvement in frailty. So in the morning we just discussed a case where there was decompensated cirrhosis, steatosis, sarcopenic obesity and frailty. So in such cases, how would you advise the intervention vis-a-vis diet and mindfulness so that there can actually be bridged to transplant, because that is the majority of kind of patients. So part of it would be preventive so that they never reach that stage. And how do you actually manage a decompensated cirrhosis for improvement in frailty?
Yeah. Can you hear me okay?
Yes.
Okay, great. Nice to see everyone, by the way. But yeah, so frailty, I mean, you probably did get lectures in this session around, or in this conference so far around nutrition and exercise. I think those are fundamentally the key for reversing frailty. We've shown in our work and others, and Sunil's work, obviously, that I showed there, that you can actually impact the LFI quite significantly with even just a nutrition intervention. Adding in exercise on top of that, I think you can compound the effect. So you get an anabolic response with exercise, right? When you're adding it to adequate protein intake. So that's going to be what you're going to need to do. Motivation's tough in these individuals, some of them, and so putting in those behavioral supports as well is going to be key. And oftentimes, what we're finding is caregiver support is crucial.
There are no more questions. I think, thank you, Dr. Punita, for being here. We would like
Thank you.
Yeah. We would like to invite Dr. A.C. Anand for his next keynote on revisiting vaccination practices in cirrhosis, spotlight on HIV and HEV.
It's a great pleasure to be part of this wonderful conference, and I'm grateful to Dr. Neeraj and Dr. Soin for giving me this opportunity. Vaccination practices in cirrhosis is a complex and a very vast topic that I've been asked to cover in about 12 to 15 minutes. Therefore, I'll try to limit myself to answering 4 basic questions. It's not moving. What is already known? Do vaccines really work in cirrhosis? What are current recommendations? And the spotlight on hepatitis A and E. What is already known is also a huge topic, but I'll limit myself to mentioning that patients with cirrhosis are susceptible to infections. Infections change the natural history of cirrhosis. Prevention of infection is therefore vital. Vaccinations can prevent many infections, and the special challenges in people who are immunosuppressed, like those on steroids for autoimmune hepatitis or decompensated cirrhosis. Now, cirrhosis is associated with immune dysfunction at several levels, which has been beautifully reviewed in a recent article in NEJM, and I'm not going to discuss that in great detail. Alongside, there is also alteration in the gut barrier as well as microbiome, leading to endotoxemia. And that makes a person increasingly susceptible for viral and bacterial infections with risk of developing decompensation, ACLF, multi-organ failure, and death. Now, infections have a huge impact on the outcome of cirrhosis patients at all stages and translates to nearly 30% mortality at 1 month and staggering 63% at 1 year. There are several common infections which are considered vaccine preventable, and we all know about them. They include both bacterial and viral infections, as are listed here. There is evidence to show that vaccines can save life, and this Lancet paper talked about millions of deaths averted and billions of years of life gained due to vaccines. It stands to reason, therefore, that doctors should use this form of intervention in cirrhosis patients to prevent decompensations and improve their quality and quantity of life. Almost all societies firmly recommend the use of these vaccines which are considered cost effective. What is the situation in India? You'll be shocked to learn that in actual practice, our gastroenterologists and hepatologists are not really doing so. An email survey using Google Forms among the 2,500 hepatologists and gastroenterologists, which are members of ISG and INASL, revealed that majority of them did not deem it important to reply. Of the 37 experts who did reply, 75%, they mentioned that 75% of the patient never receive any vaccinations, and 93% of the experts in gastroenterology were not even aware of newer modality of HBV vaccinations. So possibly one of the doubts in the doctor's mind is that whether vaccines work in cirrhosis or not. There is heterogeneity in efficacy of immunization in cirrhosis patients, which varies from near normal response as in pneumococcal vaccine to somewhat compromised response as in hepatitis B. And loss of response is proportional to the deteriorating liver function and use of immunosuppression. Therefore, the ideal time to vaccinate such persons is early in the course of disease when the liver is compensated, and before transplantation rather than after transplantation. One should avoid live vaccines in such patients, and the bulk of research that has been done is done in vaccine preventable hepatitis. We'll talk briefly about hepatitis B here and subsequently more detailed about HAV and HEV. It's not moving. Okay. This cartoon summarizes on the left side of the slide what normally happens after a vaccination, and it ends with formation of memory B and T cells. On the right side in the green rectangles, I have outlined the reasons for poorer response in cirrhosis, which includes reduced B cell reservoir and circulating dendritic cells that transform into plasmacytoid dendritic cells due to ongoing gut-derived endotoxemia. Overall response rates with standard dose of HPV vaccines are about 25 to 30% lower than in healthy people, and it worsens as the liver functions deteriorate. They are also a shade worse when alcohol is the etiology of liver disease. Using double dose intradermal administration or use of TLR booster as in Heplisav can increase the immune responses. Fortunately, but we still need to check the anti-HBs levels 4 weeks after the last dose. Response to HAV vaccines are fortunately not bad, and in compensated cirrhosis, 98% seroconversion has been reported, which deteriorates with the liver functions. Pneumococcal vaccines also take up reasonably well in patients with cirrhosis. Inactivated influenza vaccines also achieve decent response, as does mRNA-based COVID vaccination, and this last one has gone into controversy recently, so I'll not really stress on that. So what are the recommendations? I have outlined here universal recommendations on the left side, while right column indicates the optional vaccinations. More detailed reasons for the same you can get at the source, which is available by scanning the QR code. And for our region, I would like to suggest that HEV be moved to essential vaccination lists. Neeraj has asked me to highlight the vaccinations for hepatitis A and E as a spotlight. His concern is possibly related to these infections being one of the commonest precipitating events for ACLF, both in China as well as in the South Asia. India, a published report suggests that 27% of ACLF may be precipitated by hepatitis A, although HEV still leads with about 67%. 4 to 40% patients may have dual infections in various reports. These infections lead to complications in about 60 to 90% cases, liver failure in about 10 to 40% cases, and mortality in 2 to 33% cases. So let me begin with few comments on hepatitis A vaccine. We all know that HIV is endemic in India, and highest prevalence is found in the world here. We also know that HIV vaccine is highly effective in preventing the disease with nearly 99% efficacy, and universally all guidelines have clearly recommended that HIV vaccination should be done in CLD, and this recommendation is there for last about 2.5 decades. However, in India, one paper by Dr. Acharya, who's sitting here, blocked this implementation of these guidelines here. It was around 20 years back that he showed that most adolescents in India are naturally immune to HIV due to mild childhood infections. And the same study also revealed that pre-existing antibodies exist in most patients with chronic liver disease as well. And therefore, the similar results were also shown by several other workers. And therefore, the HIV vaccine was not recommended in India in 2003. But more recently, there is a significant change in epidemiology of HIV in India. With improving hygiene, childhood infections have become less common, and this disease is now seen more often in young adults, where it runs a relatively severe course. Here is one report from 2019 that says that there is increasing burden of hepatitis A virus disease in adolescents and adults in India. Another paper that shows HIV incidence among those presenting with clinical disease later in life has sharply risen 3 to 16 times. And several epidemics of hepatitis A virus have recently been reported with clinical disease in adults, and the source of epidemic being traced to either hotel food or marriage parties or contaminated water supplies. 2 years back, we were all heard about this alarming news that nearly 40 young men staying in Kota for competitive exam preparation suffered acute liver failure due to hepatitis A outbreak there. Even in cirrhosis, hepatitis A is increasingly being reported and as a precipitating event for decompensation and ACLF. And the voice is rising now to give this vaccine to cirrhosis patients in India. Therefore, it stands to reason that time has now come to abandon our previous thoughts and start recommending HIV vaccine to our patients with chronic liver disease. Ideally, one may check IgG antibodies for HIV before deciding on this vaccination. Let's talk a bit about HEV infection. There is a general impression that incidence of HIV in India is falling. Yesterday, I requested Dr. Shalimar, who's looking after the APASL ACLF Consortium database, to look at last 1,000 cases and tell me how many of them were precipitated by HIV infection. The last report mentioned 67%. He was not able to give me the exact figure because he said the database needs little cleaning, but he mentioned that significant amount of HIV infection is still occurring, although the HIV infection rates are rising. Most vaccine against HIV have been focusing on ORF2, which codes for the capsid protein, and there are 4 vaccine candidates which have been evaluated. One of them, that HIV 239, has been approved and is likely to be marketed in India soon, if it has not already been marketed. The vaccine, which comes as Hecolin, has been found to be highly immunogenic with seroconversion rates more than 90% in general population, and also has an accelerated vaccination schedule in case the epidemics occur, which has been found equally effective. During outbreaks, it has been found to be safe, though efficacy data from a study done in Sudan epidemic is still being analyzed and is not published. Vaccine immunity lasts longer than the natural infection. A note of caution for pregnant women: although vaccine is 100% effective, slightly higher number of spontaneous abortions were reported in one report from China, although the South Sudan vaccination report has not shown any increase in abortions among the pregnant women. HIV superinfection among cirrhosis is over 13 times more common than in general population and leads to ACLF with high mortality. Vaccine has been shown has shown excellent uptake in chronic hepatitis B carriers as well as in healthy controls in the Chinese studies. And another independent study showed similar result among compensated chronic liver disease patients. Yet another study published in Lancet recently as a preprint shows that vaccine is safe and 100% immunogenic in cirrhotic. Seroconversion rate or nearly 100% have been reported. And the antibody levels again last longer than the natural immunity, so we can conclude that it is an effective vaccine for cirrhotic patients. In the Europe, immunosuppressed, immunocompromised patient, that is single organ transplant patients, HEV genotype 3 and 4 is known to cause chronic hepatitis, which can be only treated by reducing immunosuppression and increasing the risk of rejection, or by giving ribavirin with associated risk of side effects. Animal model studies have shown that vaccination with HEV before immunosuppression is started provides full protection against HEV genotype 3 and 4. Even in older adults, which are surrogates for the immunosuppressed patients with age-related immune decline, the vaccine shows robust immunogenicity. So my take-home message is, infections have devastating impact on the cirrhosis, leading to decompensation, ACLF, death, and the use of vaccine is a proven method to prevent several infections. HBV, pneumococcal vaccine, varicella zoster, RSV, and influenza vaccine should be routinely prescribed to all patients with cirrhosis. Vaccines for HPV, diphtheria, pertussis, and tetanus should also be given in younger patients if they have not been already given. HEV and HIV are common causes of superinfection and should receive special attention, especially in South Asia, where all patients with cirrhosis should be vaccinated against these infections. Most vaccines with standard or modified schedules are able to produce good protection and are recommended in all cases of cirrhosis with following special consideration. That is, they should be given early in the compensated stage of the disease, before transplantation rather than after, avoid live vaccines, and check for respective antibody levels 4 weeks after the last dose to determine the need for an additional dose. Thank you very much.
Thank you, sir. I request you to take a seat on the dais. Next, we have Dr. Madhumita Prem Kumar, who will talk about point of care ultrasound and cirrhosis, a game changer for clinical decision making.
I'd like to thank the organizers for inviting me for this wonderful meeting, and it's really wonderful to see that all experts are sitting in the audience and the hall is full. So I'm talking about point of care ultrasound and hepatology practice. We all are introduced to our old ultrasound machines. We need to basically try to improve our knowledge or understanding of how we can enhance it, use it to enhance our clinical rounds, and how to use it in our daily clinical practice. So we'll be covering the whole body, essentially. But as hepatologists, we need to focus on the liver first. So you need to realize that the ultrasound machine in your office or in your ward is actually a great friend. It is a stethoscope for our gastroenterologists and hepatology practitioners, and you need to familiarize yourself. But always remember, just like the most important part of the stethoscope is the portion between the earpieces, similarly, the most important part of the ultrasound machine is not the quality of it, but the hand that actually holds the transducer and the brain to which it is connected. So let's try and see how we can improve that. So we know in our own machines, we have a linear array, which is what we use for the vascular ultrasound for line insertions. Probably this is what is most commonly used. We have the curvilinear transducer probe, which we use for abdominal ultrasound, and also when we are using guided biopsies. And we have the phased array probes, which are used by your cardiologists when they come and do your echo at the bedside. The basic ultrasound, the FAST score, is very simple. So we need to have a hands-on probably training for this, but we generally start in the substernal area, and we move in the intercostal spaces up and down, moving the transducer such that we visualize the entire right lobe. We can ask the patient to turn to the right or to the left flank and see the liver and the spleen on the other side, and from the below we can look at the hepatobiliary system. And lastly, because we are going to be looking at ascites, the kidneys, and the pelvis, the FAST scan begins and ends with the area around the pelvis. So a liver ultrasound, because we are starting from the left lobe and we start from the porta, we are actually going to be seeing the entire liver from left to right. So you just need to move the probe along and you identify the structures at the porta as the CBD, the portal vein, and the IVC. It is very clearly seen as the structures within the portal tract. And then in patients who are having vascular disease, like an acute portal vein thrombosis or hepatic vein outflow tract obstruction, this can be visualized at the bedside when you're first looking at your patient. So a patient with ascites, if you're just doing a basic ultrasound and you look at these structures, you can diagnose HVOT or PVT within 5 minutes of meeting your patient, rather than waiting for a conventional ultrasound. So to visualize this, we can actually use a color Doppler. So the IVC and the portal vein will appear very different. You'll notice the hepatic veins and the IVC have very thin walls, whereas the portal structures are slightly more refractile. So that is a good way to distinguish between these two radicals. So we have the classical lotus sign where we have the 3 hepatic veins entering the IVC. And here there's an image where I'm actually showing a tips. So you can see the tips within the structure. And patients who have undergone the procedure, you can actually visualize whether the flow is good. So you can alert your radiologist. You can actually see a patient who's post-procedure, if there's any complication, any hematoma or fluid collection. So just using the basic curvilinear probe is going to enhance your bedside diagnosis rather than waiting 24 hours till the next time you encounter the patient. So please start using your ultrasound. Coming to the hepatobiliary tree, this is an essential component. Other than looking at fatty liver, you also need to look at gallstones and the IHBR. So again, this is the same structures that we would notice at the porta. And here, this is a patient who was pregnant where we did an ERCP and we actually used the ultrasound to guide the insertion of the stent for the patient because she had symptomatic gallstone disease and came to us with cholangitis during pregnancy. So in PTBD, of course, will be done by your interventional radiologist, but US guided ERCP, simple cholecystostomy, and distinguishing of a liver abscess and a liver mass can be done by the hepatologists themselves. The next thing we need to know is today it's all about mass LD. So although we are more comfortable using the FibroScan probe, please remember in a patient with ascites, we will have to use acoustic radiation force impulse to look at the liver stiffness measurement. So at the bedside, to distinguish between a patient who's having non-cirrhotic portal hypertension or fibrotic cirrhosis, doing the LSM is a great way to distinguish whether the patient is actually cirrhotic or not. So not all bedside ultrasound machines would have that, and I would encourage you to read more about this, looking at the splenic stiffness and the liver stiffness with the same probe that you're using in your general board. So comparing the stiffness between the liver and the spleen would actually tell you that this patient, who we thought was cirrhotic because there's a nodular liver outline, but when you looked at the KPA, it's actually 7.4. So NCPH, nodular NCPH can be distinguished at the bedside with this technique. So the next thing gastroenterologists need to know about, so a patient coming with pancreatitis, a patient with feed intolerance, a patient where post-transplant, post-surgery, we are looking at enhanced recovery after surgery. So even for surgical practice or patients with, who are having some post-cholecystectomy complications, you can do a ultrasound. So looking at the gastric volumes in a patient in feed intolerance or in a patient who's undergone an ERCP and you're looking for early varices, you can actually see the peristalsis quite beautifully. You'll see that the food is actually moving around in the same area and it's not getting forward. Gastric residual volumes are high. So in the ICU, we are routinely looking at this to look in terms of when we should be altering the kind of NG feed that we are giving, whether the patient requires a smaller residue or longer spacing, or we require prokinetics. So this is a good way to look when you're doing your abdominal ultrasound, just look at the intestinal varices. And of course, in patients with IBD, there's good evidence of looking at bowel thickness. So for the gastroenterology colleagues, please start looking at bowel thickness with your ultrasound as well, because it can really enhance the way you're managing your patients, rather than waiting for a CT and rather than waiting for your sonologist to come and give you some impression which they would, and they would generally come and write normal because nobody looks at this. We need to look at it because we are clinicians. The next thing that is of importance is now cardiovascular mortality in patients with liver disease. So rather than looking at things below the diaphragm, we need to look above as well. So looking at just, even if you're using the ultrasound, the curvilinear probe, and you place it in the substernal area, you can actually see the left ventricle quite clearly. In a patient who's critically ill, who's had a sudden onset hypotension, just looking at the LV, if it is contracting properly or not, will give you enough information. It's called a visual ejection fraction. We don't need to calculate it, but it will give you an idea that we need to alert our cardiologists, we need to alert our intensivists, there might be something that is going wrong with the heart. Simply looking at the heart muscle can give you a great idea as to whether things are all right with the cardiac system. My area of interest is cirrhotic cardiomyopathy, and the worst thing that happens with most people when they're undergoing echocardiography is that the cardiologist writes no MRTR, ejection fraction is normal, normal LV systolic function, and sends the patient back. That is not an adequate assessment of cardiac status, because most deaths in patients post-transplant, they occur not just because of obstructive CAD, but because of weakness of the cardiac muscle, which is cirrhotic cardiomyopathy, or right heart failure, or pulmonary embolism, or arrhythmia. So if the electrolytes are not managed, there could be a sudden arrhythmia, there could be a pulmonary embolism, and this is sadly missed in most of our patients because we are not looking at CCM. So remember that patients with cirrhotic cardiomyopathy will have normal LV systolic function. They will have preserved ejection fraction. So you need to ask your cardiologist, what is the cardiac output of my patient? Is the patient having hyperdynamic circulation? And if the right heart is normal. So looking at the RA-RV, looking at the tricuspid regurgitation is going to give you great information whether there could be a sudden cardiac event. And of course, HPS and POPH is diagnosed with bedside echocardiography if you should so desire. But you need to ask your cardiologist for it. So all patients with cardiac disease will actually have a very hard-working cirrhotic heart with hyperdynamic circulation, and only in the end stage will the ejection fraction go down. So now that we are looking at improved understanding of imaging, for example, in CT and MRI, we are asking for LIRADS reporting. We are talking in terms of HCC diagnosis in terms of LIRADS. Similarly, for your cardiac evaluation, you need to be asking your cardiologist to report the entire spectrum of disease, not just obstructive CAD, but CCM, right heart disease, and also valvular disease. So the basic echo that we would need to know is by looking at the apex. So if you have the phased array probe, we put it at the apex. If you don't have a phased array probe, no problem. Use a curvilinear probe and use it at the substernal area. You will be able to see at least the left ventricle, and you will be able to see the right ventricle, and be able to have a gross impression whether the biventricular function is okay or not. But for the diagnosis of CCM, we require some specific variables like the mitral valve Doppler. We will require the left atrium size. So in the cirrhotic heart, the LV doesn't pump adequately, that doesn't relax enough, so the left atrium actually dilates. There could be tricuspid regurgitation in patients especially with portopulmonary hypertension, and on basis of these variables we can detect whether the patient has cirrhotic cardiomyopathy or not. Can be done at the bedside in all of your patients with the machine that you're currently having. So CCM is actually an underdiagnosed entity. It is there about 25 to 30% of individuals. In decompensated cirrhosis, and in patients who have variceal bleeding or refractory ascites is there in up to 50% of individuals. It is also closely associated with HRS-AKI and is associated with sudden cardiac deaths, especially after transplant or TIPS. The next important thing that all of us need to learn is looking at the fluid resuscitation. So a patient coming with AKI, are they pre-renal? Are they just dehydrated? Patient coming with variceal bleed, you have given blood products. Are they going to go into flash pulmonary edema or volume overload? So looking at the IVC and the distensibility or the collapsibility of the IVC, and mechanical ventilation is going to be distensible because of PEEP. You measure the IVC just near the hepatic vein, proximal to the entry into the RA, 1 centimeter behind. And if it is more than 40%, it means that there's a wide variability in the volume of fluid within the IVC, and therefore this patient is going to respond to volume expansion. So in patients with HRS-AKI, you diagnose that they are fluid replete on the basis of IVC indices. It is now part of canon and as part of all the guidelines. So if you want to classify patients with AKI, you need to do an IVC. If you want to give volumes and prevent ARDS and pancreatitis, you need to learn this technique. It is really really simple, just needs you 5 minutes to spend with an expert. The next thing we are going to talk about is the velocity time integral, which is the volume of blood that is pumped out from the left ventricle into the aorta. This is an easier thing to measure than the IVC, but you'll need hands-on trainings, which we'll talk about later. So volume assessment based on the IVC collapsibility. This data, this table is freely available on the internet, and you can use it to describe the volume status of your patients. So in patients with HRS-AKI, majority of them might actually be fluid replete at the time of presentation because they have received fluids outside. So some of them may directly require vasoconstrictor. Some of them will require further volume expansion. And some of them may actually be fluid overloaded. And in those patients, if you start pushing them with albumin, they'll end up with pulmonary edema. So here you will need diuretics. So about 5 to 10% of patients may be volume expanded. Here, if you're starting to give too much of terlipressin or too much of albumin, you will say it is a complication of terlipressin. No, it is a complication of us not diagnosing the volume status correctly. So this is how POCUS can actually enhance. Like I said, right heart estimation in POPH and pulmonary embolism. So here you'll see the right atrium is very distended. Everything is regurgitation. This is a patient with pulmonary embolism. Looking at the cardiac function after TIPS, so not just looking at the echo with ejection fraction, you need to look at the right heart as well. So any patient with a GLS which is less contractile, that is more negative, they are going to have worse survival after TIPS. So again, TIPS assessment, which is very commonly done, especially for bleeds. And of course, heart failure and obstructive CAD remain the biggest cause of death after malignancy in patients following liver transplant. So in this meeting, we definitely need to be knowing about how these patients need to be assessed even after transplant. So CCM can actually affect patients with sepsis. Of course, this is an area of critical illness, and incorporating the CCM variables within the MELD, just like MELD lactate, actually enhances the predictive value of the MELD score. And looking at the cardiac index, if it reduces with time, you can actually predict the patient who's going to die before any clinical event actually occurs. So using POCUS at the bedside can also be used to predict whether the patient is likely to respond to terlipressin. Again, we look at diastology variables here, E by E prime and E prime velocity. This is a little bit specialized, but at the very least, if you're looking at cardiac assessment and the cardiac output is falling, this patient is going to do worse on terlipressin. So that's the way you can use it in clinical practice. Fluid responsiveness, as I mentioned, looking at the change after passive leg raise, fluid bolus, or the change in the IVC collapsibility can help you in your clinical practice. And the cardiac output assessment, which is required for your cardiologist, please start asking for it. So the cardiac output assessment and the contractility of the LV is going to give you a great idea. So again, we use this data to predict whether the patients will have which phenotype of HRS, and we found that patients with HRS-AKI and AKD, there was a close association of cirrhotic cardiomyopathy. So right at the outset, when the patient first presented, we proved whether the patient is likely to respond to fluids or to terlipressin. So this is my summary slide. The heart-liver axis is an important component, and then other than basic abdominal POCUS and basic intestinal POCUS, we need to learn about looking at the cardiac axis in patients with liver disease and in patients with IBD. So I will complete here. And I would like to use this opportunity to invite you to INASL. This is going to be in August 7th to 10th at Chandigarh. If you're interested in getting a hands-on POCUS training, we have slots for about 20 people, where 3 experts will give you A to Z training on POCUS. So please feel free to reach out to me in case you're interested. Thank you.
For the next keynote, I would like to invite Dr. S.K. Acharya sir, who needs no introduction to this audience. He will be talking about how he has seen hepatology evolve in the last 2 decades. Dr. Acharya sir.
Thank you, Dr. Saraf and Abhi, for inviting me here. I'll be very honest with you. When I saw this, I had never thought about this, because senior to me, Dr. Kosi is there, Dr. P.N. Rao is sitting here, and if you ask me how I have seen, or they have seen hepatology growing, when we started the gastroenterology fellowship, there was no hepatology, first thing. It was gastroenterology. Just like when gastroenterology was not there, it was all general medicine. The first thing, when I joined, there was no hepatology at all. However, PGI had a department of hepatology way back for certain political reason, right? Not for a branch which has evolved, right? I don't want to go into the detail because Dr. Kosi and Dr. Rao is knowing about that. But when Neeraj asked me about this, there are many youngsters, I started thinking there is no literature on it. There is no research, there is no prospective trial, there is no randomized controlled studies or retrospective evaluation. I remember as a resident, we could diagnose cirrhosis. And they used to come with variceal bleed. We didn't have fiber optic endoscope. I think Dr. Rao and Dr. Kosi will agree. We didn't have fiber optic endoscope, right? And we will put in blindly a Shanks-taken Blackmore tube to arrest the bleeding. And clinically, if the spleen is palpable with a GI bleed, I remember Dr. Nandi telling me 95% of them has variceal bleeding. That is what we started seeing. Then there was semi-rigid endoscope, and which was first practiced in South Africa by a surgeon called John Terblanche. And you will be surprised, he's the first man to start sclerotherapy in this patient of variceal bleeding. I remember reading that was first published in a journal called SGO, Surgery, Gynecology and Obstetrics. The journal number exists. So that was the beginning of the hepatology. And now you see, during last 2 days, you have seen where hepatology has reached. So this is to start the ball rolling. If you, from 1980 to 2025, hepatology has become a discipline. Hepatology has become, if you see, the knowledge has exploded, resulting in listing hepatology societies, dedicated scientific meets because you need to discuss, dedicated journal and hepatology courses. In this country, we have hepatology DM in 5 or 6 medical institutes, and people are doing only DM hepatology, no more gastroenterology. That's what I have seen. We have just seen Madhumita speaking on further advancement using POCUS, right, point of care of ultrasound in hepatology, how you can, right. So the imaging, the laboratory, the histology, the etiology, disease spectrum, complex, everything has expanded. And we have now hepatology sub-branches. When it started, there was no hepatology. Now there is hepatology sub-branch, transplant hepatology. You just heard, it's a distinct division. Endo-hepatology. You have 2 courses, 2 lectures on endo-hepatology after this. This has become absolutely specialized, which you never thought, right? Interventional hepatic radiology, hepatic pathology, and now AKI, hepatic nephrologist. Now there are sub-branches of hepatology, right? Whole demographic and etiological spectrum I have seen changing. We had at that time hepatitis, viral hepatitis. Diagnosing hepatitis B and C in 1980 was difficult. It was hepatitis B or non-A, non-B. Hepatitis C was diagnosed in 1989 by Chiron Corporation, right? We hardly, till that time, hepatitis C was not diagnosed. You'll be surprised. So, hepatitis is no more a problem. It's all behavioral disease, alcoholic liver disease, mast cell, diabetes, comorbid diseases, multiple diseases. And liver cancer. I remember when I used to see liver cancer, tell them go back. There is no treatment. Now you have seen how the treatment of liver cancer has advised. And particularly chronic liver disease. You have seen how incremental advances in every component of management of ascites, management of variceal bleeding, management of HRS-AKI, non-HRS-AKI, management of sepsis, Now, dividing chronic liver disease to compensated advanced liver disease, further classification, right? Decompensation can be ACLF, unstable decompensation, stable decompensation. For management approach for each is different, right? And treatment of end-stage liver disease. Liver transplant obviously is a different ball game. Now we have various forms of support system for the liver as a bridge to transplant. And most advances is in Mesocaval, multiple drugs you are seeing, and multiple evidence-based guidelines, which we never saw, sir. I think Dr. Rao and Dr. Kosi will agree, there is no guidelines for treatment for any liver disease, right? Now you see for everything there is a guideline, right, indicating huge amount of information. Now this is a holistic evolution. Now if you see specific, eradication of viral hepatitis. I don't want to go into this. Acute liver failure. Mortality was 90%. Now, with various treatment, including transplant, survival can be 90%. Portal hypertension. Starting from Sang's-taken Blackmore tube, we have now advanced not only to various endoscopic therapy, various radiological intervention, and endo-hepatology. Now, using US, you can also block shunts, treat ectopic varices. Now, way back, Harold Kohn gave a diagnosis, identify SBP, and told 90% of them die. Today, 90% of them survive, and he has indication of liver transplant. ACLF is a new form of liver failure, and the tertiary HBOTO, you do not subject them to shunt surgery with a 45%, 50% mortality. You just do a TIPS. Autoimmune liver disease, incremental evidence, starting from steroid and other immunosuppression. Now you are treating refractory AIH with anti-CD20 or anti-CD19. So that is the type of advances, HCC. This is a different subject altogether. Now, Mesocaval again is another subject and huge number of therapy. Obviously, the rest of the therapy is using. Hepatitis, I did not go into this. You all know, I will just go through the slides. And now recently, you see, World Health Organization recommend treat everybody with hepatitis B. We are treating guideline-based patient who had disease. Now we have gone to treating everybody. So these are few slides which I am showing, which are there. Now you understand whole spectrum of Mesocaval now, and various aspects of Mesocaval, which has become a major form of disease. And well, if you remember, hepatitis B has high endemic, and that was at best more than 8% in China, Taiwan, Southeast Asia, to low, middle endemic, which is about 2 to 4%, and low endemic 2%. See, Mesocaval is 30% of your global population. There is no other disease which is so much prevalent. And that's what you know. And you have identified the pathogenesis and pathogenic and therapy directed all at this pathogenic drivers, which you have been discussing, right? I did not go into this disease, and you have just heard about it. These are various agents which you are now hearing in multiple meetings. Just I told about advances in chronic liver disease. In 1980, when new endoscope came, you will not believe we have fiber optic endoscope. Dr. Rao and Dr. Kosi will agree. And after some period of time, the fibers will break. Once the fibers will break, half of the field will go. And it's very difficult to replace those fiber optic endoscope. And we will be asked, sclerotherapy has started. And I remember Olympus produced the first sclerotherapy needle. And with that half-seen fiber optic endoscope, you have to inject them to stop the varices. We used to do it. Now today it is all different, right? This whole, even diagnostic endoscope, forget our therapeutic endoscope, has changed. And Many of the youngsters would not have known all these things, but except for me, Dr. Rao and Dr. Kosi, probably very few other people would have seen all this. And I don't want to go into this, right? And various, from Sankstein Blackmore tube, we have come to Denisova stent, right? When there is a failure to sclerotherapy, right? And there are multiple studies on this. Now, prevention of bleed. Now, various aspects of prevention of bleed using various modality has been discussed, right? And one of the major advances, I think, in treatment of chronic liver disease for refractory ascites, for hydrothorax, for portal vein thrombosis, for variceal bleeding, is a stent inside the liver, which is not there. And non-invasive test to determine cirrhosis or advanced fibrosis, multiple. You just heard a lecture about that, right? And using this non-invasive step, you can risk stratify the chronic liver disease. And depending upon the risk stratification, you can predict the future outcome, which you used to never do. All cirrhotic come with a decompensated state. Then only we know that he has cirrhosis. Because today, the access with ultrasonography, first, everywhere it is available. There is a fatty liver disease. There is a raised transaminase, which is not there, right? Now you can risk stratify them and treat them. The mortality when we started, I have just pointed out. See, now after 2010, with all this therapy, the mortality in the treatment, this is a visible difference. People cannot imagine. And you have various forms of preventing bleed. And the guidelines for various type of prophylaxis is very clear. So you can categorize the form of therapy today, which is not there, because we didn't know how to treat these patients, right? I remembered Harold Kahn's, in 1980, I read a book called Viral Hepatitis, written by Harold Kahn. And in the preface, in fact, Steve Serene was 1 year senior to me. Dr. Kosi was 3 years by the time he's gone from AIMS. And Dr. Rao must be in PGI at that time. We were a very initial group of people who got trained. And that time, few people were very famous. One of them was Kahn, who is the fellow who described constipation causes hepatic encephalopathy, increased protein load causes hepatic encephalopathy. He described SBP. He wrote a book called Viral Hepatitis. And in the preface, I had never forgotten that preface. He wrote, well, my patient calls me a great physician. Because viral hepatitis was very prevalent then. And he will say, when patients with viral hepatitis will come to me, I assure them, look, there is no treatment, but nothing will happen, go back. If you don't improve, you come back to me. Those who come back to me, because of mild rise in liver enzymes, I poke in a needle into their liver. Liver biopsy was there by that time. I poke in a needle into their liver, like a baker pokes his needle into a cake to find out whether it has been done with or not. Pak gaya ki nahi. When I find evidence of chronic liver diseases, I assure them, look, nothing to worry. It's fine, go back. If you have distended vein in your foot pipe, that time barium swallow, endoscopy has just come in, then come back to me. Those who come back to me with distended vein, I assure them, look, nothing to worry, go back home. If you have a bleeding, then come back to me. Those who come back to me with a bleeding, I admit them, give transfusion. And any time 30% attrition is there, they will die. Though by chance survive, within a year, 30% will rebleed. The rebleeding per year was 30%. So each time there is attrition. So at the end of 5 years, those who survive, they come to me and tell me, indeed, Dr. Kahn, you are a great physician. You are a great physician. Ladies and gentlemen, that was the time what we saw in liver disease. And today, what you saw is this liver. Every step of those, right? You have device therapies, intervention, salvages, and continue to expand. Because I suddenly remember that disease. So these are these few slides and treatment of liver. You have stage, and now Dr. Seri told, this is obsolete. Now he said, the stage-related prognosis and allocation of treatment is obsolete. Now treatment is curative intent. Every patient who has a good liver function, right, must be tried to be treated with a curative intent. A concept of downstaging using multimodality treatments, which is everything. This has also changed. Immunotherapy. Now, we didn't understand tumor microenvironment liver. Liver was an immunotolerant organ. That's what we knew, right? Otherwise, food, which is a foreign pathogen, would have caused continuous liver inflammation. And there are mechanisms how liver is tolerant. That has been cracked. And various anti-tumor agents has been devised, right? I don't even want to go into the detail, even prophylaxis, liver transplantation. Now, you'll be surprised, Journal Hepatology indeed wrote, I tried to search the changing face of hepatology. And what he says, this changing face, what I told, it is not about that. This is changing face of hepatology, what is coming. So it is like Robert Frost saying, the jungle is dark, green, and deep. Before I have to go miles before I sleep. There is no sleep for hepatology. It is continuing to grow. And you see, the future is now AI. Madhumita, what is trying to say, AI will be integrated to your diagnosis of focus, machine learning. Now genomics predicting treatment of liver cancer. Even massively, genomics we have learned. Critical care has become a division completely for liver function, post-transplant, pre-transplant, critical care. Fecal microbial transplantation, I didn't discuss. Regenerative medicine, we don't have a drug for the liver to regenerate. And that's the future. And that's the day we are waiting, because we don't have a drug till now. And the type of drug delivery is also going to change. This is what this change, right? Using nanotechnology, peptide-based and genes-based. Now you have developed biobank for it. And most important is digital twin, right? It's the digital world. Now you can have a model of liver on the digital world in a virtual model and try your therapy and diagnosis. And that is what is coming in future. Thank you very much.
Thank you, sir. That was a very insightful lecture. We have 5 minutes time for discussion, and house is open for questions and answers.
So what is number needed to treat in case of vaccination? To prevent one infection, how many pneumococcal or herpes zoster or influenza vaccines are required?
I don't think so that information is available anywhere. The response rates to pneumococcal vaccines are around 98%, and protection is also quite good. But number needed to treat, vaccine is a preventable disease. It prevents the disease. And you cannot predict how many people are going to have infection.
In non-cirrhotic population, Dr.
So I was coming to that only. We have data on number needed to treat in general population, and the number needed to treat for influenza vaccine in general population to prevent one infection is somewhere around 175. For pneumococcal vaccine, it is around 35. I am sure these numbers would be, because the incidence in cirrhotic patients is much higher, these numbers would be much lower in the cirrhotic population and post-transplant population. Just to give you an overview about the vaccination in chronic liver disease patients, the epidemiology, the influenza is actually threefold higher risk of acquiring influenza infection than a general population, 8-fold higher risk of developing a severe disease, and 16-fold higher risk of dying of influenza than a general patient. So that is the magnitude of risk, and vaccination, as Dr. Anand was mentioning, is a very important aspect in a cirrhotic patient.
Dr. Anand, do you suggest hepatitis A vaccine for all cirrhotic without testing for antibodies?
No, I said ideally you should check for antibodies. If people are old of my age, they will probably be having IgG antibodies in any case. So they will not require vaccination. But younger people, yes, you should check for the IgG levels. And if they are negative, you should vaccinate these people.
But Dr. Anand, the whole population has changed. Now the cirrhotics are alcoholics. And the mean age of these alcoholics are between 20 to 40. And they start drinking early. This is a different group of population. And I don't think we have data on that. That the study which was published by me, that was 25 years back.
That's true.
Right. That they have.
We'll give you that data next year.
Right.
Sir, do you really feel that influenza vaccine which is now available every year by WHO will do good? The one like Ectopic which is coming every year with a new strain? Rather than, asking the patient to get vaccinated separately.
Sorry, I didn't get the question.
The influenza vaccine which is available, the WHO strains come every year in the month of September, October. Separate vaccine.
No, no, same vaccine.
Same vaccine.
Because same strains will affect the...
Sir, number two, sir, do you advocate even the pneumococcal vaccine to be given, the multivalent, pentavalent, which one is basically?
Pneumococcal vaccine comes in two forms in India. One is with 13 strains and the second one is 23 strains. With 13 strains is the first dose that you give, and after a period of 2 to 6 months, you give a second dose of 23 strains.
Dr. Anand, shingles vaccine, which has been recommended for adult people more than 60, all diabetics and high risk group. So our CLD patients are also high risk. Many of them, they have underlying diabetes.
Yes, that is included in the recommended vaccines.
So
Yes.
generally, what I have seen, most of our patients, they don't get it. So
Yes, that
we
is
should
what-
have this in recommendation.
That is the shocking part of our practice in India. This survey that we conducted, it shows that majority of people didn't think it was important to reply. It was too routine a thing to be talked about. But there were about 40 people who replied, and out of those 40 people, they said that 75% of their patients do not get vaccinations.
Why don't you ask Anand how many of
And-
them give vaccine in this audience?
And
Raise your hands.
Not only
See?
that, not only that, of the
5%, 95% don't give vaccine.
And of the 40 people who answered the question, 93% did not know that there are more effective vaccines available than routine hepatitis B vaccines. How many of people here have heard about Hepatisav? Nobody has heard. So these are the things which are happening outside, which probably we should be aware of to make it more effective for chronic liver disease patients.
So herpes zoster is very common after transplantation, very common. Pneumococcal we see it is rare, but herpes zoster is very common after transplantation.
Yes,
Any
it is
comment of
recommended.
professors?
So, Dr. Narendra, I want to make one comment. Herpes zoster is very common after post-transplant, and the other problem with herpes zoster post-transplant is that it can cause a disseminated disease, which is a problem in post-transplant patient. So, herpes zoster vaccine now, earlier it used to be a live vaccine. Now we have a recombinant vaccine which we can give to our post-transplant patient also. And it is one of the vaccine which in general population has a vaccine efficacy of 98% and 90% in immunosuppressed hosts, which include the transplant recipients. Second point with regards to the pneumococcal vaccine is that, see, pneumococcus is, strep pneumo is a very innocuous kind of a bacteria. It is a bacteria which is till now sensitive to penicillin up to as high as 80-85%. So whenever we have a patient who is presenting to us with any respiratory complaint, we will throw some augmentin, some fluoroquinolone, some doxycycline. Because that is a very susceptible bacteria, those antibiotics would take care of that infection, and we would not be actually diagnosing that this pneumonia was due to strep pneumo. So that is the problem with that. Coming to strep pneumo incidence in a post-transplant patient, if you look at data from US, 2% of all the hospitalization in US were actually due to pneumonias which included strep pneumo, which could have been prevented. 2% of all hospitalization. So that's a huge number.
Dr. Madhumita.
And development of pneumonia in a chronic liver disease patient means entirely different thing than it means in a healthy person. In a healthy person, you give 5 days of levofloxacin and he improves. But a chronic liver disease patient may have acute and chronic liver failure and other organ failures with that.
Dr. Madhumita just wanted to pinpoint in one of your slides when you're talking about LSM, the IQR median, to my knowledge, is supposedly to be less than 30%. Anything above 30% is not considered to be a real thing. Because your slide shows 57%, so I just wanted to on your point.
Thank you, but you see, point of care ultrasound is we don't need to be perfect. We always have a safety net of the real sonologists who will do it. I completely agree with you. So the point of care devices are not well attuned to also do it. They give you an idea of what is to be expected and we can get a confirmatory test. It's just that the first time you see the patient, you have a ready diagnosis available.
Dr. Madhumita, IVC focus is as good as IGV focus.
Absolutely, and only thing in IGV focus, most of the time we have central lines, and in patients with cirrhosis, it's, they have 10 cystitis, so IVC is also difficult. So that's why we started doing IGV, but then they started having central lines. So now we are doing the velocity time integral. It is very easy to do. We directly place it on the apex of the heart, and you see the blood flow that is coming out with every heartbeat into the aorta. And that gives an excellent idea. There could not be a better gold standard than looking at that for volume status. And please do learn the technique. It's very easy to do. I'm happy to train.
Just one comment. Always a pleasure to listen to both of you. Your knowledge and experience, Dr. Acharya and Dr. Anand, has always been something that we'll be proud of, even in every conference of ours. So thank you, just from our side. Madhumita, just one additional thing that I would like to add, which we use almost every day. ALF patients, ONSD and PCD, transcranial Doppler, very, very good. Even intraoperatively, we've been using it now, especially when you don't get under anesthesia or under sedation, the pupillary reactions. You use it even for the pupils, contralateral side, with illumination. And the second is about the chest. So evaluation for A lines and B lines bedside with focus. I think that's the other thing where it is very useful, especially in these patients who come to pleural effusion or with pneumonia. So just 2 points.
Thanks, Dr. Prashant. I ran out of time. We had slides on lung ultrasound, optic nerve sheath diameter, transcranial Doppler, and also on muscle ultrasound. So assessment of sarcopenia, sarcopenic obesity can also be done at the bedside. So you can do everything in one go, all in one. So because you can quantify it. So in a critically ill patient like the case we were discussing in the morning, if you do the thigh ultrasound and you also do it at the ankle, you can actually determine whether the patient is improving. So rather than just doing CT, LFI, you can just measure the size of the quadriceps femoris. And if it is improving with time, well, we're getting better with sarcopenic obesity. You can also see myosteatosis with the ultrasound. So at the bedside.
We are running short of time and we need to end. So we request all the experts to gather on the left side of the dais for a photo. And for the next session on video lectures, I would like to invite, sit down, the moderators for the session, Dr. Sanjay Bajal, Dr. Abraham Koshi, to take their seats on the left side of the dais. The expert discussants for the endo-hepatology session are Dr. Gaurav Chawla, Dr. Piyush Ranjan sir, and Dr. Abhinav Sharma sir, to take stage on the right side of the dais. The first video lecture is by Dr. Sahaj Rathi. He will be giving it online. He will be talking on endoscopic ultrasound guided transgastric shunt obliteration. ETSO, Dr. Sahaj Rathi.
Good morning, everyone. At the outset, I would like to thank the organizers, Dr. Saraf, Dr. Soin, Swapnil, and the entire Medanta team for inviting me for this session of endo-hepatology. And I shall be speaking about EUS-guided transgastric shunt obliteration. I have no financial disclosures. However, these techniques are novel and the data is limited around these. So the next 10 minutes will be more experience-based than evidence-based. So endo-hepatology, as we all know, is a rapidly evolving subspecialty, which is kind of a collision specialty between hepatology and advanced endoscopy, where we use endoscopy tools to provide better diagnostic and interventional procedures for patients with liver disease. The most commonly used indications for endohepatology are gastric variceal obliteration, liver biopsy, and portal pressure measurement. Most of these other procedures are in the investigational realm. We can do shunt modulation like obliteration and eversions that we'll talk about today. We can use it for acute portomesenteric thrombosis for thrombolysis in select cases, oncological ablations and oncological assessment in HCC. We can use it for advanced portal hypertension assessment, assessment of its complications and vascular liver diseases, and certain other indications. However, for now, we'll restrict ourselves to the mandate of shunt obliteration, whether it be for gastric variceal obliteration or for hepatic encephalopathy. So let us start with gastric varices because that is how the technique was born. So gastric varices, as we all know, can sometimes be very problematic, especially if they are very large or actively bleeding. However, EUS makes life much easier because it can show us the varix in its entirety, and we can document complete obliteration by way of Dopplers. So, for example, here in this case, we can see the varix and we puncture it with a needle. We inject coils to provide a scaffold for glue to polymerize, and then we inject some glue, and that leads to complete obliteration of the varix. We can see the thrombus forming in real time, and then we can use color Doppler to make sure that there's no more flow in the varix anymore. And head-to-head comparison with endoscopic glue, at least retrospective studies have shown very encouraging data. There's a higher clinical success with lower adverse events when US was used opposed to endoscopy. However, there are certain issues that do crop up. One of those being gastric varices are by nature large and ectatic, so sometimes they may require multiple coils, which becomes very expensive. It increases procedure time, and because these coils are not designed to go through needles, at least at their inception, they sometimes may get stuck, in which case things get difficult. And then there's the issue with artifacts. It makes subsequent imaging, both EUS and CT, very difficult to read. So if we can minimize the number of coils or take them away entirely, that would always be helpful. So we took some inspiration from radiology techniques, where in BRTO they go retrograde, inflate a balloon or place coils and plug, and this leads to stasis and obliteration of the varix. Sometimes radiology does a similar thing and in an antegrade manner, going across the liver parenchyma and through the portal vein. We decided that we can achieve something similar by using EUS, by injecting coils and glue into the afferent of the shunt, and that will lead to thrombosis of the entire shunt, including the varix. So just to demonstrate how that works, this is a patient with what seemed to be multiple fundal varices on endoscopy. However, on CT, it looked like the entire thing was a part of a single conglomerate. There was a very large shunt associated with it, almost as big as the kidney, and the feeding vessel was a left gastric vein in the gastrohepatic ligament. So here we can see the entire variceal conglomerate. It's quite spread out. And this is the gastrohepatic ligament. We can see, we are in the stomach and we can see the liver over here. And we are injecting coils and glue into the left gastric vein, which led to almost complete cessation, but there was still some flow remaining. So we took another puncture and injected a little bit more of glue over here. And please take a note of this loop of the varix over here. We can see that in real time, this is becoming hyperechoic from anechoic. So this was a loop of the varix that was going this way. And just by injecting glue in the right place, we were able to create complete thrombosis and elimination of the entire shunt along with the gastric varices. And this is the CT before and after. We can see this entire large shunt has now become atretic. So can we do something similar for patients with refractory hepatic encephalopathy? Because there's now a fair amount of data that patients who have large shunts, they actually benefit from shunt obliteration. So most of the large portosystemic shunts actually arise from areas that are very easily be accessible with EUS, most of them being splenorenal or recanalized paraumbilical or sometimes portorenal. So with EUS, we can target these shunts in the same way as we do for gastric varices and achieve similar results. So let me demonstrate here a similar case of shunt obliteration, but this time using a large paraumbilical shunt. This was a patient with refractory hepatic encephalopathy. So we find the paraumbilical shunt arising out of the left lobe of liver, and we find a good bend, a tortuosity in the shunt where a coil will remain stable, and then we inject some glue over there, and as a result we see complete cessation of flow because of thrombus formation. And this is the result. This is the before and after the venous phase reconstructed images. We can see the large shunt does not show any contrast opacification, and here are the coils that we placed. So from our experience, we had a very high technical success. Granted, we've done only 11 cases of these, but most of them had a good clinical success, did not have recurrence of overt hepatic encephalopathy in most cases. No major procedure-specific complications, although we did see complications due to development of portal hypertension like ascites, but usually they would respond well to diuretics. While this worked for most patients where we did the procedure, there were some patients where we could not do the procedure because of poor hepatic reserves. So we always wondered, could we do something more for these patients, because not everybody will be able to get a transplant. So let's see how the decompensation works. When patients who have a large shunt, when we close the shunt, the inflow from mesenteric as well as the splenic vein go towards the portal vein. And in patients with poor reserves, this may lead to decompensation and development of ascites. However, if we were to close the splenic vein in certain patients with a certain anatomy, we may be able to use the shunt as the splenic outflow. So the liver will not be congested because the splenic outflow is now not going towards the liver but going directly into the systemic circulation. While the portomesenteric inflow, which carries gut-derived toxins, will actually go towards the liver and not cross over to the systemic side for the most part. And this would help with hepatic encephalopathy. There have been certain case reports and case series of a splenic vein embolization being done surgically as well as radiologically. However, this does not seem to have gained a lot of popularity, probably owing to the morbidity of surgery and the transhepatic and the transsplenic access required for radiological embolization. However, when we do it with EUS, it's actually a very simple and straightforward approach. We just identify the splenic vein, puncture it with a needle, and using the similar techniques as we described for feeders and for varices, we inject coils and glue into the splenic vein. And this leads to obliteration of the splenic vein. So in our overall experience of 159 EUS guided obliterations, most of these were gastric variceal obliterations. Some were for refractory esophageal variceal bleeding. And the bleeding data will be presented by our fellow Dr. Arpit Shastri in Barcelona in a couple of weeks. And then 15 cases for refractory hepatic encephalopathy, of which 11 were shunt obliteration and 4 were shunt diversion, that is portosplenic split. So comparing EUS guided procedures with standard interventional radiology procedures, what we realized the advantages were a much lower cost and procedure time of between 10 to 20 minutes usually. And there was no limitation of having a gastrorenal shunt, which is actually required for most retrograde procedures. Irrespective of the kind of shunt there is, we can perform the procedure for most patients. Fluoroscopy is not needed for most cases anyway, and EVL can be done in the same session if the patient has large esophageal varices, which is important in patients when we are doing shunt obliteration. But then we have to understand that this is a novel procedures, so there is a paucity of evidence and there's no head-to-head data, but hopefully we'll embark upon some of comparative studies in the near future. And then there's always the issue of learning curve, because portal hypertensive vascular anatomy can sometimes be very complicated and tortuous. So to conclude, EUS shunt obliteration and shunt modulation is feasible for both varices and hepatic encephalopathy. Technically, it is feasible for almost all cases, and usually anatomy is not a barrier for most procedures. EUS allows for a potential personalized approach to the patient. Knowledge of vascular anatomy, Dopplers, and injection key techniques are very important. Currently, the evidence is limited, but it is rapidly evolving, and we hope to see more and more evidence on this external validation in the future.
Thank you, Dr. Sahaj. We request you to stay with us. We will have the Q&A at the end of the another video lecture. So for the next video lecture, I will like to call Dr. Narendra Chaudhary. He will be talking on endoscopic ultrasound guided management of ectopic varices. Dr. Narendra.
That was great, Sahaj. You have done phenomenal work. No one else has done in this country. I will speak on ectopic varices. These are uncommon. Primarily, modality of treatment is IR guided procedure if TIPS or BRT are possible. Sometimes these are not feasible immediately or due to cost or high child or MELD. So here comes role of EUS or upper GI endoscopy. 66-year-old male, decompensated cirrhosis, LRM lesion, child C, SPP, AKI, so varicic, and he presented with PR bleed. We can see active bleed from one of rectal varices. EUS guided therapies for ectopic varices are similar to what we do for gastric varices. 19G needle, we have punctured this rectal varix. This is fluid being injected to confirm position, bright artifacts of coil. You look at this, this is outside vessel, and this also gets obliterated in this procedure. So this is post procedure, beautifully obturated varix. Case 2, 63-year-old male, cryptogenic cirrhosis, child 13, jaundice, ascites, HA, coagulopathy, melena, EVL done outside, and there were recurrence of bleed. This is upper GI endoscopy showing active bleed from duodenal varix. So when we do endoscopy, it is always better to go as deep as we can go, because this patient had bleed from duodenal varix, but 2 times he had EVL. This ectopic varix was not picked up in endoscopy. It is at D2, D3 junction. We see active bleed. This is endoscopic glue. But despite glue, because this is a large varix, it doesn't get obturated easily, and we can see that despite endoscopic glue, there is still active bleed is going on. And varix is soft to touch. EUS guided, EUS guided coil was placed. Due to difficult position, half of coil is inside varix, half was outside. So again endoscopic glue was done. This is endoscopic glue. This time, because coil is there, this glue is retained at this side. And we can see this varix is changed in color now. This is at the end of procedure. Patient died due to comorbidities, but there was no bleed. 33-year-old male, EHPVO, a distal duodenal varix, glue was injected, CT abdomen showed large collaterals, and again there was recurrence of bleed, glue injection failure. So basically he had bleed from this side, we injected glue, and once we removed that needle, he started bleed from this side also. EUS image, coil being placed, and when we initially we used lipiodol, so we could see it in fluoro. Nowadays there is, even with EUS guided coil, there is increased risk of embolization with lipiodol, and we don't use. Pre-procedure CT showing large collaterals, and post-procedure shows these collaterals are obliterated. 52-year-old male, LDLT for MASH CLD, biliary stricture, portal vein thrombosis, hyperesplenism, and bleed. Small varices in esophagus, stomach normal, no gastric varices, D1, D2 smeared with blood. And we noted, so there is ectopic varix in D1. Sometimes ectopic varices are difficult to pick up because they are not as apparent as gastric varices on endoscopy. EUS shows flow in this varix. This is coil and glue. This is post-LT portal hypertension generally doesn't happen unless there is recurrence of cirrhosis or portal vein thrombosis. So we could see splenic vein and SME, but portal vein is not visible. These are artifacts of biliary stents. This was before EUS guided therapy of this ectopic varix in June. We repeated endoscopy in December, and we see this ectopic varix is gone. So what are differences from EUS guided gastric varix interventions? Ectopic varices are difficult to pick up. EUS cannot go everywhere, so ileal or jejunal we need IR guided help. Still there is more data on tips as compared to EUS guided therapies. We should know anatomy properly, so a pre-procedure CT is needed. And if ectopic varices are small rather than a combination of glue and coil, it can be glue or coil alone. Adverse events, so these, we can see a coil here. We use lipiodol and glue, and these bright white spots are pulmonary embolization. Again, we can see pulmonary embolization in CT. Coil is here, so a location of varix is here, and this lipiodol and glue is going this. So this is accidental injection of this glue and lipiodol into LR shunt. This CT confirms that. So when we do procedure of these patients, we explain that possibility of embolization is less. All these embolization images are from gastric varices, not ectopic varices, but risk is there. So we explain them that risk of pulmonary embolization is less, but it is there despite using EUS. So for ectopic varices, active bleeding, we can do EUS guided therapy. For recurrent bleed or elective cases we see if TIPS is feasible. If TIPS feasible because it cures portal hypertension also, these patients go for TIPS. We can use EUS guided coil and glue in emergent cases. It is easily done like we do for gastric varices, excellent obturation rates. As I said earlier, if small size, we can use glue, or if we are bold enough, like Sahez, we can target feeders. We need to explain adverse events, and IR is always there to help. Thank you.
Thank you, sir. That was an excellent two video sessions. The house is open for questions and discussions on the endo-hepatology sessions.
Narinder, let me ask you first question. Approach to ectopic varices, does it depend whether the portal vein is patent or whether the portal vein is
Yeah, I'm here.
obstructed? Because if the portal vein is patent, probably the ectopic varice is obstructed. Ectopic varices will form again and again. So trying and opening up the portal vein would be a better strategy in that case.
So Dr. Basil can answer that question.
So I think over the last 10-15 years, we've also in IR undergone a transformation. We've started looking at CTs differently. And the more we look at it, we realize that even in chronic portal vein obstructions, there are tracts which now tell us that yes, portal veins can be reopened. It's great if you have intrahepatic portal vein flow, but then you have an inflow or outflow. Otherwise, we do what we discussed yesterday in the PVR. So conceptually, re-establishing flow through an obliterated system is a root cause being addressed. I agree with Piyush there.
So this patient, that is post-transplant PBT, actually we reopened that portal vein. Initially when there was no bleed, we tried anticoagulation, but after bleed, we did this EUS procedure and we asked Dr. Basil to open. So now we reopened that portal vein by IR procedure.
Naren, I feel leaving the part of coil outside the varix is not a glitch or not a mistake. Rather, it is a sure-shot way to ensure that the coil stays there.
So, okay, so coil stays there. We can see that in varix, it was accidental that part of coil is left outside. But if it is outside, don't worry for that.
Sahaj, one question to you. Sahaj.
Yes, sir.
In the
Am I audible?
procedure, how do you ensure that coil does not migrate to portal vein?
Right, that's an excellent question. Am I audible in the hall?
Yes, you are, Sahaj.
All right. So, as opposed to shunts and as opposed to varices where you have tortuosities that can keep the coil stable, with splenic vein, that option is not there. So the point is that we should always ensure that we have adequately oversized coils, number one. And number two, I always, so this is based on data of 4 patients. We have done this case 4 times now. So we place multiple coils, so at least 2 or 3 coils, so that the coils get tangled among each other. And while we are inserting the coil, the needle kind of helps to hold the coil in place. But I would always say that the coil has to be oversized by at least 30%. Otherwise, we may be in trouble because there's nothing to stop the coil from just moving away. So that's something that we should always be mindful of. So that's a very good point that you raised, sir.
So, sorry. So initially we used to aspirate blood in needle and confirm that we are inside varix, but then you need to use lipiodol because there is blood inside needle. Even if you flush, this glue is stuck inside. So nowadays, if I feel that yes, it is a large varix, I am inside, so rather than aspirating blood, we inject saline, we confirm, then we use undiluted glue that decreases risk of embolization.
So, Sahaj, do you need a pre-procedure imaging in form of CT to decide about your injection in cases of gastric varix? And in gastric varix, whether you would straight away go and inject the varix itself or target an afferent if it is feasible, which one is better? And size of coils, if the afferents are large, do they matter?
So, sir, all three very pertinent points. Number one, regarding the size of coil in afferent when the afferent is kind of small, I mean rather large. So usually afferents are not very large. Usually afferents are relatively small as compared to varix. The varix itself is in the fundus. There's a lot of space for it to grow, so it grows much larger. So the afferent is relatively smaller, so usually oversizing the coil is not a problem there. Sorry, your other question was, can you please repeat that?
Do you need a pre-procedure imaging and
Pre-procedure imaging, yes.
if possible, would you target the gastric varices or the afferent? Which one would be better?
Right. So, sir, regarding these 2 points, pre-procedure imaging, if we are doing it as an elective procedure, I always try to get a pre-procedure CT because that limits the time spent inside the patient. So that cuts the procedure time considerably. However, if it is an emergency case, then I'm not too worried about it because usually the patterns of the afferents are pretty much fixed. It's either left gastric, posterior gastric, or short gastric, which is going to supply the gastric varix. And it's relatively not very difficult to actually trace it down. It does take a little bit of extra time. So if we have a pre-procedure CT, that is always great, especially if in situations where we may have multiple feeders. It is good to know beforehand. But if we don't have a pre-procedure CT, I would not say that's the end of the world. It can be done with a few extra minutes within the patient. And the second point, which is a very pertinent question and is a part of personalized medicine in patients with gastric varices, is whether to target the varix only or whether to take care of the entire shunt. I think that depends on two major factors. One, the liver reserves, and two, if there is any portosplenic thrombosis already evident. So liver reserve in the sense that will this patient be able to tolerate an entire shunt obliteration? If the patient has a MELD of 15 or more, has ascites, or has jaundice, then in those cases, my focus would preferably be to just take care of the part that is bleeding. And if there's an extra gastric collateral, let it be, because that is basically helping decompress the portal system and acting like natural tips. And the other point would be, if there is splenic vein thrombosis, we should be extra careful because that gastrorenal shunt may be the only outflow for the spleen sometimes. So in those cases, we may want to restrict to the varix alone. And the third situation would be the presence of ascites, because if we are targeting the entire shunt, then we have to do a puncture that goes extra gastric. And that's a situation that we should avoid if the patient has ascites. So these are the three situations where I would say that we should target the virus. And in other cases, I think targeting the entire shunt by going into the afferent actually works out to be a much more pragmatic solution for the patient.
Can we have the question from the floor?
Dr. Bajal. Sir, question to Dr. Bajal. Sir, you've seen the procedure. What are your worries in this EOS guided procedure from your IR experience?
Sorry, no. So I've seen Sahaj and his presentations many times, and they're always tremendous. So, like all procedures, like he said, these are going to mature, and they will, as they move and the data becomes better and more robust, they might even become standards of care, which is, I think, the best. At the end of it, it's the patient who wins, and that's what all of us want. But currently, what Narendra concluded was a very more pragmatic and practical thing, that you do the essential requirement, stop the bleeding. If it is encephalopathies, obliterate the shunt, But if you can reduce portal hypertension, permitted that the patient is a candidate for TIPS, I think that's a more complete strategy. And if you're doing a TIPS, you can just go ahead and do it. The other thing I would say is that I think EUS is a tremendous tool. I think it's a tremendous tool, and we also feel very impressed by it. But for example, if you have to occlude a paraumbilical vein shunt, it can be very simply done percutaneously. You just puncture the shunt, it's under the skin, and get access to it using a simple 5 French vascular sheath and just occlude it. So the effort should be to keep it simple so that anybody and everybody can do it. Like Sahaj said, there are learning curves. And so if you can minimize learning curves and procedures and get them quickly out into practice, I think that's where the key of developing new treatments lie.
Question.
Orko, last question.
Right. It's not a competition between the endoscope test or the radiology. Whatever is best for the patient needs to be done. Second is whether we inject a coil into the gastric barracks, shunt, or the afferent. In general, the perforator is always it's much smaller than the barracks. So I personally feel, this is my personal opinion, it kind of depends on individual situation. What is the size of the gastric barracks? How many coils are we going to need? How affording the patient is. If you're just injecting into the perforator 1 or 2 ml glue would be sufficient. So that significantly decreases the cost of a patient who might be presented to PGI, a poor patient in an emergency situation. So those are the times we can do it. Other thing I also find, I think Sahaj would also say this, as compared to ETS, EPSS has got certain advantages in the sense that toxin-laden blood flow that goes away, but the nutrient-rich blood can go to the liver. It's a more difficult thing, but I really wanted Sahaj's opinion on this. For gastric varices, finding out the afferent efferent is easy. We do it back to our stuff. The other things which might be tricky. What's your opinion on doing a variceography and then seeing it under fluoroscopy to see which way the contrast is going and then maybe finding out that?
So, Alka, that's an excellent question. Variceography. I hope I'm understanding this correctly because the volume was a little bit low on my side, but you were asking that whether variceography will increase our understanding of the anatomy of the varix. The short answer would be yes, it will definitely increase our understanding, but the flip side would be to do a variceography. Usually, the 19-gauge needle for a large varix, even the most concentrated omnipac will move too fast. The 19-gauge needle, even when we inject fast, the contrast just kind of loops in and disappears. So it's not very easy to pacify the entire varix unless we have already reduced the flow to a certain extent. And I personally do not feel, at least for gastric varices, it gives us the incremental addition of information that is required for patient care or for understanding that we already do not have with EUS. So that's for gastric varices, I would say the incremental benefit of doing that is very limited. However, when it comes to shunt obliteration, sometimes I find that very useful for shunt obliteration and for the split procedure, because after you place the coil, you inject a little bit of contrast to see if you've been able to slow down flow adequately or not. In certain situations, I've used it. We don't have enough numbers yet. This is a procedure in its infancy. So I think over time, when we do more of these, we'll probably know better. But as of now, I try to use fluoroscopy when I can for shunts, but for gastric varices, I wouldn't feel strongly about using it.
So no variceography for gastric. Just 1 second. I'd just like to invite all of you to NASL in August, and I will be in PJ Chandigarh, and we will be having a workshop on endo-hepatology. It will be a restricted workshop for around 20 students. So those who are interested can please register.
One last comment from Dr. Gaurav.
So Sahaj, inspired by your work, we also did a recent ETSO procedure for one of patients with recurrent hepatic encephalopathy, and patient is doing well. But just only thing is sometimes we don't see a bend from where to inject is the most critical, because we be seeing a shunt entirely between the portosystemic area, but where to inject in that area, sometimes we don't see a bend that time. And post-procedure optimization of diuretics, beta blockers, antibiotics, because as you know, liver reserves is an important question. So we should restrict them only to MELD less than 10 or CTPA only, or between 10 to 15 is the area where we should be like more cautious and more.
So, sir, first of all, thank you very much for using this technique and congratulations for doing it successfully. And actually, we are compiling an external validation of ETSO. We are actually compiling a manuscript, and I would welcome anybody who has done this procedure now to please, if they are willing, contribute these cases, because we are in the process of compiling a manuscript on this now. And when it comes to what is the good med score, usually 15 to 16. Dr. Bajal can actually give a better opinion on this, but personally for me, I think 15, 16 is a med above which I feel a little apprehensive in closing shunts completely. We have done staged closures in the past, and then when EPS was developed, that became a go-to for patients who were fragile. But um, anything above, I would say 18 is definitely going to be a no-no for me. For 15 to 18 would be strict caution, because those patients will decompensate once the portal pressures rise after a successful shunt obliteration.
Thank you, Sash, for being there. We are running short of time. We request the expert
Thank you.
discussants and Dr. Narendra to take their seats in the audience. The moderators should stay on the dais. And for the next video lectures on intervention radiology, we would like to call our expert discussants, Dr. Sachin Chakravarti, Dr. Sonal Asthana sir, Dr. Soumil Singhal, to take their seats on the right-hand side of the dais. And the first video lecture will be delivered by Dr. Anubhav Khandelwal. He will be talking on Mesocaval shunt for splenoportal thrombosis or extrahepatic portal vein obstruction, if I'm correct. Dr. Anubhav.
So just echoing to what Dr. Bajal said, we are always amused by the great work that you can do with EUS and endoscopy, and the scope is tremendous. So I'm here to present a very simple procedure, yet very useful, and it's a creation of mesocaval shunt by endovascular route. So we've seen developments in the management of portal hypertension and variceal bleeding has significantly caused reduction in mortality in past few decades. Pharmacologic and endoscopic therapies have become the first line for prevention as well as treatment for variceal bleeding. And TIPS, liver transplantation, and surgical shunts are usually considered once the first line therapy fails or are not possible. However, surgical portosystemic shunts have decreased drastically after the advent of endoscopic therapies, TIPS, and liver transplantation. So in event of splenoportal thrombosis, TIPS creation may become technically difficult or unfeasible, and that basically depends on the chronicity and extent of obstruction. In such cases, if a surgical shunt is possible, then it's always considered leading to decompression of variceal bleeding. However, shunt surgery may still not be feasible in most of these cases and may carry a high mortality risk if done in emergent settings. So even for these patients, a non-surgical image-guided endovascular portosystemic shunt creation is possible, and this can be done by connecting IVC to SMV or a major venous collateral using fluoroscopy or ultrasound guidance. So this is a case example for the same. This was a 39-year-old male patient, and he was a diagnosed case of EHPVO, had splenectomy in past. There was portal cavernoma causing portal biliopathy with recurrent pyogenic cholangitis with hepatocolithiasis. And there was history of multiple endoscopic biliary drainages with multiple stent exchanges. Patient also had multiple episodes of bleeding in past and was admitted this time with the recent episode of cholangitis. This is the CT scan of this patient, and as you can see, there is thrombosis of portal vein with transformation of portal cavernoma, which was extending to both right and left portal vein. Also can be seen major venous collateral, which is coming off from the SMV, and if I would just show this, yeah, so some abscesses in the liver, biliary dilatation because of portal biliopathy, endobiliary stents in situ. So careful evaluation and then multiple options were discussed for decompression of the venous system. Surgical shunts was not deemed feasible in this case, and the alignment of the major venous collateral allowed us to plan endovascular creation of a connection between this major venous collateral, which was coming off from SMV, and connecting it to the infrahepatic IVC. And we thought if we could connect this, then we can place a covered stent there, creating a mesocaval shunt. So orthogonal planes were also assessed to see that there was no critical structure. The path was discussed, and it looked feasible via transjugular approach using the same technique that we use for dips. Bring in the tips cannula, make it reach the infrahepatic IVC, and then try to get access to this venous collateral. The only thing was that we needed real-time imaging, and we thought of ultrasound can help us. So this was used, and we tried to see if we can see both the structures, the venous collateral as well as the IVC in one frame. So in a longitudinal scan, this is what the ultrasound showed. This is what the CT looked like. This is IVC, and you have that major venous collateral here, which was coming out from SMV. And this is again the IVC and the SMV there at the anterior end. So a TIPS cannula has an angle, as can be seen here. This was brought down the jugular route into the infrahepatic IVC, and you can use a stellate catheter combination through that cannula and advance it through the wall of IVC anteriorly. So just to put things into perspective, this is what it looked like. So you are coming down the IVC. This is the infrahepatic part of the IVC, and a path to access the collateral is demonstrated here. This is what it looked like in real-time ultrasound. You can see the indentation on the anterior wall with the stellate catheter combination, and that's the mesenteric collateral which was to be accessed. So a puncture was made into that SMV collateral, and then a venogram, the needle was removed, the catheter was kept there, contrast injection confirmed that we were intravenous. The access was secured over a wire, a balloon dilatation of 6 mm was done, and then a sheath was secured into that venous collateral. Venograms were taken both from IVC as well as the venous collateral, just to have an idea of the stent graft that is going to be used. Taking all the measurements, stent graft was placed into the path across, bridging the IVC and the collateral. And again, before deployment, again a check venogram just to see that the position is correct and we are secured well into the IVC. Stent deployed, balloon dilatation done, and that's the mesocaval shunt which was established, decompressing the venous collaterals. This is a follow-up on ultrasound for this patient after 1 month. After the procedure, patient was discharged on anticoagulants. This is the follow-up. You can easily visualize the stent on the ultrasound, shows good flow through it. So we've done 4 patients till now in last 1 year, and all of them have patent stents. So I would like to conclude that in patients who have splenoportal thrombosis and where TIPS is not feasible and also surgical shunts are not feasible, creation of this by simple technique, this mesocaval shunt can be considered for these patients as salvage treatment option. Thank you.
we request Dr. Anupam to take you to a seat on the dais, and we'll have the Q&A at the end of the session. For the next video lecture, I would like to invite Dr. Aman Mukund sir, and he will be talking on portal vein recanalization tips, that's PVR tips.
So, good afternoon all, and at the outset I would like to thank the organizers for having me here. So it has been a wonderful session, starting with endo-hepatology and followed by IR, and especially, the case what Dr. Anupam showed really is a mesmerizing case and very intricate and very, done with very minute details. So moving to portal vein recanalization tips. So actually, I think the order of the talk should have been PVR tips followed by Mesocaval tips. So anyway, in a reverse fashion, going to PVR tips. So quickly going to the case. So a 54-year-old male, EHPVO since 2010, index presentation upper GI bleed, and he developed ascites in 2021 and developed rapidly refilling ascites in 2023. So that was a refractory rapidly filling ascites. This was the CT scan in 2020. If you see in 2020, so there are varices, a case very similar what Dr. Anupam showed. So this was in 2020, and at that point of time, he was given an option of PVR tips, but since there were no complications, like GI bleed was under control, no varices, so the patient didn't want any further management at that point of time. So he came in 2023, so this is what we see. So you can see ascites, portal biliopathy has developed now. You can see the biliary radical dilatation, more of collaterals again becoming more thin. And this is how, and if you see here, there is no portal vein. There are multiple calcification as well in most of the segment. So this is how it looked on CT scan. These are the ultrasound images. If you see, this is the ascites. This is how it was looking here. And again, going by such kind of cases, and till the time in 2023, there was huge literature regarding portal vein recanalization being done through transsplenic route, and that is one of the most preferred route across the globe. So this is how people are doing. But there are certain reports where people are using transhepatic route also, and there are some people still sticking to the conventional way of transjugular. So, with this ascites not being very comfortable, again, more of a conventional person, I thought, let us try transjugular. Let us see what happens. So we tried, and definitely we take a ultrasound guidance. If you see in the shadow, it is an ultrasound probe. So somebody is showing me an ultrasound, and what we see, there is some flow of contrast. So then when we went inside, we found that this is a collateral. So this is a dominant collateral. So we had an option of doing a collateral tips, but sometimes you're not satisfied, you're not happy whether you should do a collateral tips or not. Again, this is a treatment we could have done, but we took our catheter out. We kept trying, and maybe after another 45 minutes or 1 hour of extensive work in cath lab, we found that something is looking like native portal vein, and it was blocked over here. Only some flow was seen on the left side, nothing on the right side. So we kept working on it, like how we do it for all kind of arterial occlusions and venous occlusion and bud carry. So a lot of struggle, but we were able to get into we passed this occlusion, we were into it. Again, this was the part which was further occluded, and this was a calcified segment. But fortunately, we were again able to cross that calcified segment. And now we reached into the portal vein, but what we see that all the flow is being diverted to this large collateral, and these are the cavernoma which is seen. If you see here carefully, this is the cavernoma, this is the segment, and then we went deeper inside again, that is seen nicely, but only some flow is going into the portal vein. So we dilated this splenic venous segment. We dilated the whole portal venous segment, and this is some of the images which you can see, and then we took a run. So still there was some flow. Now we can see some flow coming towards the right portal vein branches, some into but still the cavernoma is filling. And what we saw that even the superior mesenteric vein is blocked. So we went into the superior mesenteric vein, and this segment is blocked. If you see here, again, the whole bunch of collateral is being supplied by the superior mesenteric vein. We dilated the superior mesenteric vein as well. So we thought whether we should extend our stent into the superior mesenteric vein as well as the splenic vein, but we thought let us not do that. Let us just keep our stent short. And then we placed a stent, and this is how it was looking after there was no collateral filling. So this is the run. If you see a beautiful run, which is decompressing the whole system, this is the right portal vein, which is seen. You see here, this is the right branch of portal vein. This is the left branch of portal vein. So actually, we have placed a short stent just after dilatation, and this is what we got. And this is a 6 months follow-up, no ascites. You can see up to the pelvis, there is no ascites in this patient. This is the Doppler study in 3rd of May 2024. Again, a nice flow, no ascites. And this was a case image which was done for NCCT because the patient had lung infection. You can see here consolidation. But fortunately, there was the upper section of the abdomen where we can see there is the stent and there is no ascites. So patient, after 2 years follow-up, is still doing well under follow-up. So this was one of the cases. There are many such cases which I can show you. Quickly going through the second case, again, you can see here, nothing seen, only echogenic cord-like portal vein. So there is no cavernoma. So here, there is no possibility of doing a collateral tips as well. And this is how it was seen on Doppler. But yes, if you are good, somebody is good at showing you an ultrasound like endosonology, endo-hepatology, where you see nicely through the stomach, we can see nicely through our transabdominal ultrasound, and somebody guiding you nicely, you can actually get into it. So we went inside that fibrosed portal vein, and everything was away. So this is the kind of varices what you see. And this is how it is supplied. And this is one of the varices. So there was some question regarding varicography. So it's very difficult, even if you see all the varices on ultrasound, on angiogram, it is very difficult to actually understand which one is going where and which one is actually supplying. So anyway, just into it. But what we saw, there is thrombosed here section, there is no SMV. And then we went inside, then everything was towards the varices. When we placed the tips, we saw that everything got thrombosed. So these are the complications. We cleared it. Again, after clearing, we see some thrombosis. And then finally, it takes an hour, multiple hours where you clean all the thrombus, and finally, you keep the tips working. So yes, it's a long procedure. And Dr. Anubhav said that it's a simple procedure. So him being very modest, he has done 4 procedures along with Dr. Bajal. I feel they have done a wonderful job, and those are one of the most complicated procedures what they have done. So another case, this is a Budd-Chiari syndrome where even the portal vein is, the hepatic vein is not there. Along with the portal vein, we can see the cavernoma over here. These are the regenerative nodules. You can see the cavernoma. This is how it is. So the patient doesn't have hepatic vein, doesn't have the portal vein. Again, as going by my way of treating, so I go transhepatic, and first we entered. So this is how, initially when you go, you may encounter some vessel, you can see some extravasation of contrast, and these are scary moments. Suddenly you say contrast going into the peritoneal cavity, into the liver parenchyma, and you are not getting into the true veins. So yes, adrenaline rush is very high. And then you again go inside, again you find every time you puncture one vein, you find that it is going into some different, a bizarre kind of a venous system. But if you are consistent, at some point of time, you may find that you have actually reached a portal vein, and then you can go inside, recanalize that portal vein, and then you can place a tips. So yes, it takes time, but not so difficult. So this is how, and finally collateral tips can be done where it's too difficult, chronically thrombosed portal vein. You can see calcification. This central part is the calcified, and this patient was again a 60-year-old male who lived his life all throughout with this EHPVO and came with ascites, and we had no other option than to do a collateral tips. And these images are too scary to see. Sometimes you are not sure whether you are into a dominant collateral or not. And But we did it, and it was decompressed, and his ascites also resolved. We were able to keep him ascites-free for about 2 years, and he lived for around 4 years after TIPS. It was one of the initial cases. We did it in 2013. And then just to show you images how PVR TIPS is done through transsplenic route, you can see the catheter coming here, recanalizing the portal vein, and finally you can keep a marker over here like a snare, puncture that, and place a TIPS stent. So this is how a TIPS stent is placed, and this is a follow-up image for the same. So coming to the final slide, IR options in EHPVO. So it may be portal vein recanalization. We are not talking about it, but in coming days, probably more and more people will talk about plain portal vein recanalization rather than a TIPS. You definitely have an option of portal vein recanalization TIPS. It may be transjugular, transhepatic, transsplenic, transmesenteric. And you may have a combined transsplenic, transhepatic, transjugular, or transmesenteric, transhepatic, transjugular. So you can connect all these mesenteric vein, splenic vein, portal vein from any direction you want, or you can take all the direction to recanalize it, place a stent, and establish a flow. Mesocaval shunt, very nicely demonstrated. And finally, if you have good collaterals and you don't have an option of recanalization, you may go to a collateral TIPS. So this is from my side. Thank you so much for your patient hearing.
I have a question for both of you. From the old surgical experience, we used to say when you use a collateral, the patency is not as good as when you use a normal vessel. What is your experience?
That's why, sir, in that particular slide, collateral TIPS is the last option. So first we start with portal vein recanalization, and let us go by analogy of Budd-Chiari syndrome, where we see wherever you can open the hepatic vein or IVC, you just re-establish the anatomical and the physiological outflow rather than creating a shunt. So option is not to create a shunt. Option is to re-establish the portal flow. In case the intrahepatic portal flow is good and the liver hasn't gone into fibrosis, maybe if F1, F2 fibrosis, it's a very good case where you just recanalize the portal vein and everything would be fine. Then if that is not possible, again, you can place a stent in the portal vein. And finally, if that is not possible, then portal vein recanalization along with outflow, that's not possible, then a shunt, like Dr. Anubhav said, and that's actually, that's truly a wonderful case what he has shown. So yes, these are stepwise procedure, and probably we'll be coming out with how to go step by step. So as we know, in Budd-Chiari, we have a step-by-step management. Similarly, we may have something like that in portal vein recanalization as well.
Hi, Dr. Anubhav. So that was amazing. My question is, what is risk of bleed in such procedure, and in case this stent gets blocked in future, can you reopen it?
So one part, I'll say if you are doing transhepatic, risk of bleeding is much less. But if it is, mesocaval shunt creation, I think Dr. Anubhav has more experience than me. He'll elaborate.
Yeah, so the risk of bleeding is obviously there, but the only thing is that we're just taking the shortest route, and we are taking just one wall puncture. Actually, if you look at the literature, there are techniques described where you do a percutaneous puncture from anteriorly into the collateral, and then you take a needle through and through the collateral into the IVC, and then you snare the wire. So over there, the risk of bleeding has been documented, but luckily in our procedure, we didn't have any major bleed happening in any of the patients. In fact, not even a smaller bleed. Another thing that we take care of is that once we have the access, we do not balloon dilate to full 10 mm. We actually do a small 6 mm ballooning, and we immediately slide the sheath across the path so that the risk of bleeding is not so much. And once our stent graft is in place, we deploy that and we do a post ballooning. So that's there. Another thing is that if the shunt occlusion is there, if you see we're coming from the SVC side and then going down so that's more physiological flow for the collateral also. And once if we have to ever intervene and open those shunts, then also we can come through the jugular route, come down, cannulate, just like any other tip stent that would get blocked, and we'll open it.
Two questions, Dr. Amar. So in the first, one of the cases which you showed, that you had the SMB which was also blocked, you just balloon dilated. So is it worthwhile placing a stent in the SMV also? Extending your stent to the SMV? And number two, what are the general indications? Would these be patients with portal vein thrombosis, portal cavernoma, who have portal biliopathy and subsequently developed ascites, or actually cirrhotics who have portal vein thrombosis? They would be a very difficult subset of patients for these interventions.
So coming to the first question first. So regarding putting a stent in SMV, splenic vein, so in my experience, overall long-term outcomes of putting any stent in these venous system doesn't give us a very good result. The occlusion and thrombosis rates are pretty high. It may not be in a year, 2 year, but it maybe 3rd year, 4th year, and these are very difficult to open once they thrombose, because initially if they thrombose early, it is patients are asymptomatic. Until the time they become symptomatic, it's already fibrosed thrombosis, and getting into those thrombosis stents is difficult. So I generally avoid, because opening a native vein is always easy, or a big collateral is easy than opening a vein. But sometimes you have an immediate recoil. You open and it blocks immediately. So you have no other option than to put a stent. So I generally wait for some time. If there is any opening, I'll just open the portal vein and then. Coming to the next side. So yes, there are two subset of patient. One is cirrhotic, one is non-cirrhotic. Again, in cirrhotic, PVR tips is the best option. You should, and the patency rates is very high because they have a portal hypertension and then you treat. But PVR tips in EHPVO per se is not a very good option, because again the portal pressure is not very high, overall liver is not very good. So eventually the flow is on a slower side, thrombosis rates are high. Now treating which patients? So they are the best treatment for bleeders. If they are bleeder, definitely you will get a very good outcomes. But if it is biliopathy, then you have to be cautious. Whether it is a ischemic biliopathy or it is a cavernomatous biliopathy, whether it is just a compression of the cavernoma. If it is compression of the cavernoma, opening these collaterals will help. But if it is ischemic at the lower end, may not, even after having a very good flow, you may need a surgery, HJ, for relieving that biliopathy.
So I had one question. This was regarding on how do you decide whether to do recanalization or recanalization with tips, because clearly the liver quality will make a very big difference, isn't it? Would you normally do a liver biopsy to see whether there's fibrosis before you took that decision?
So yes, if you ask me, in my personal opinion, because there is no level 1 or level 2 or even level 2, 3 evidence to suggest, so there will be no consensus on these. It is only experts' opinion. But if you ask me, if liver condition is good, if you already have a liver biopsy in the form of TGLB, or even if you have a good fibroscan where you know that KPA is less than 7, 8 or something 5, 6, then you should try to open a portal vein, and if it is openable. If it is absolutely not openable and the patient is coming with recurrent bleed, then definitely whatever is the best option, opening a portal vein or doing a PVR tips, and if not, then finally I think Mesocaval shunt. So that's how we decide how to go about it.
Sure. And the second question was regarding to your first case, where there was a big collateral runoff. So would you consider embolizing the collateral or maybe sightening your stent in such a way that you exclude the collateral?
So if that collateral is actually contributing to any of the bleed, because this collateral was predominantly going towards the liver side, suppose my stent gets blocked, at least the liver perfusion will remain and the outflow from the SMV will be patent. So I won't be happy doing it. But if it is on the splenic side, going towards the esophagus or gastric side where it can form a varices, because it is mostly the splenic vein axis which always leads to bleed. Rarely it is the SMV side which actually goes towards that side and cause a bleed. So that's an important consideration where we do that.
Thank you.
Amar, I always pick his brains, by the way, when I have a doubt in my mind. So here's another one for you. Now there's a lot of talk about lowering the diameter of the tip stent for ascites, and I think you have written a consensus on that, in which we should now think about using 8 mm stents. At the same time, like your first patient where there was a large volume ascites and we are doing a PVR tips, very often in PVR tips we don't get a pristine clean inflow and we still see shaggy walls of a portal vein, and we anticipate over time the portal vein will become clean. So are we with lowering the tip's diameter and leaving a semi-thrombosed inflow, are we worried about a failure in these patients? Or in this scenario, we should stick to our good old 10 millimeter stents?
So in case we are unable to open the portal vein nicely, and the segment where we are putting a stent that's good enough to accommodate a 10 millimeter stent, yes, 10 millimeter would be a better option rather than 8 millimeter, because the chances of thrombus moving upward and occluding those is very high. And despite giving a very good optimal dose of anticoagulants, they may not open, and we may not just keep giving them thrombolytics, and nobody gives thrombolytics per se. Even after the procedure, thrombolytics are totally stopped. So yes, anticoagulating them is a very good option, but in such a case where you have a shaggy portal vein, where you feel that the portal thrombus is cleared but not up to the 100%, maybe 90%, with some thrombus sticking to the wall, those are the most chronic one, then yes, 10 millimeter is still a better option, because these patients may have a slightly better liver reserves, and encephalopathy may be, of a lesser degree, they may not actually have a encephalopathy if adequate measures have been taken by our hepatology colleague. So yes, that's one area. Like, we are not very much scared in Budd-Chiari syndrome. We are not very scared of encephalopathy in EHPVO in a normal cirrhosis. But in cirrhotics, yes, we need to be very careful, especially in Indian subcontinent, where most of the patients are sarcopenic, and having encephalopathy is very high, as what has been described in Western side. So we need to be careful.
So one small question: when would we, how long would we wait using a conventional methods to resolve encephalopathy? And sometimes, because it happens that encephalopathy happens late, and it's difficult to assess whether other factors are causing the encephalopathy or it's the tips that is causing encephalopathy. So how long should we try routine treatments, and when should we go for a reocclusion or reducing the size of tips, or maybe a partial occlusion?
So if patient has done well with tips and then he has developed encephalopathy, definitely encephalopathy is also because of over-shunting. So that over-shunting needs to be taken care. But if that over-shunting is not overburdening the heart, it is only taking something from the intestine and which is causing all disbalances, maybe electrolyte, ammonia, or whatever we know. Maybe ammonia, may not be ammonia. So then first we need to see whether the patient is following all that your advices or not, and whether everything regarding those anti-coma measure has been taken. So if anti-coma measure has been taken and it is a recurrent phenomena, it has to be a recurrent. One time doesn't determine a patient can have encephalopathy, even just has cirrhosis with normal shunts what he has. So that is a very important determinant. If it is recurrent, we need to reduce it, or sometimes we may even require to close it.
Just a quick doubt.
Yeah.
Do you start anticoagulation in all your patients post PVR?
PVR, it depends, like what is the thrombus load. In cirrhotics, generally I avoid, but in non-cirrhotic, I may give it for 3 months and reassess. So it's not a lifelong anticoagulant, it's a time-bound anticoagulation, maybe 3 months, extended by another 3 months, maybe we'll withdraw it.
How do you decide when to stop? Based on?
If I see a good ultrasound after 3 months with no thrombus there.
I think the discussion can go on, but we are running ahead of time. So I thank you all the experts, and I request all of you to join us at the backdrop for a photo, and request the discussion from previous session, Dr. Gaurav Chawla, Dr. Piyush Ranjan, and Dr. Abhinav Sharma also to join in for a photograph. For the next session, I would like to invite, that's a very interesting session, the rapid fire round on everyday hepatology. Would like to call our panelists, Dr. Sagnik Biswas, Dr. Sudhir Maharshi, Dr. Manas Panigrahi, and Dr. Mallikarjun Sakpal to join the stage in the center, and would like to invite our speaker cum moderator, Dr. Manav Vadhavan, for the rapid fire round on dilemmas and controversies in clinical practice.
Thank you, Swapnil. Thanks, Neeraj, for a clinically based, interesting session for me to host. We've heard what experts do with endo-hepatology, with stent placements and all. This session is primarily going to be a clinical session. We have no literature to discuss here. We have cases which we see every day in our ICU or in our ward. and what each of us would do. So the format is very simple. I'll give one slide of the case. I'll ask the audience to vote for what they would do in such a case, and then we'll ask the esteemed panel which we have. We have 4 experts here, Dr. Mallikarjun, Dr. Manas, Dr. Sagnik, and Dr. Sudhir, to deliberate on what they would do and why. So let's jump right into it. Case 1, 56-year-old diabetic male on OHA for 20 years, takes some alcohol, 10 drinks a week for 15 years, which actually is significant for a person who has cirrhosis. He comes to you with hematemesis and melena for 1 day. There is no other decompensation. There's no jaundice, no ascites. He only gives a history of swelling feet off and on for last 1 year, for which intermittently he has been given diuretics since he was diagnosed to have cirrhosis. We do endoscopy. It shows large high-risk esophageal varices with no red signs as such. GOV2 is seen with a nipple sign present on the GOV, and there was blood in the stomach. So as a primary management, what all of us would do, we injected gastric varix when we vented the esophageal varices in the same setting. Question is, where do we go from here? So this is a bleeder. He's got large gastric varices. He's got large esophageal varices. You have taken care of the index bleed here. So this is what we do in our clinical practice. Every gastric varix undergoes a triple phase CT to see the extent. Because one injection in a gastric varix may or may not control the bleed for subsequent sessions, and see what we see here. The posterior wall of stomach is full of varices. So this plane I have taken below the glue injection just to show you the load of gastric varices. So this guy had extensive gastric varices to deal with. We have injected, we have controlled the bleeding. What would audience do? The options are, 1, try to eradicate varices by endoscopy, whether using endoscopy for, EVL for esophageal varices, use glue or coil, EUS guided coil for gastric varices. Second is do a balloon retrograde transference obliteration. Third is do a TIPS. Fourth is do a TIPS with antegrade obliteration of gastric varices. Voting, please. So the options, most people want either follow-up endoscopies or TIPS plus antegrade obliteration of gastric varices. Very few takers of only BRT or only TIPS. So let me start with Dr. Mallikarjun. What would be your approach and why?
MELD score, did you tell us?
So no decompensation, MELD 10.
Yeah, then I think better will be the go ahead with the TIPS, because that will give the long-term better outcome in this patient, and there is extensive varices.
No, but okay, so you would go ahead with TIPS alone. Dr. Manas.
So sir, if active bleeding is there?
No, active bleeding we have controlled. We have already injected the gastric varices. The bleeding is controlled. We presume that seeing the white nipple, the bleed was from one of the gastric varices, but they are extensive gastric varices alone. The question I want to ask you is, for the audience sake, are you happy with TIPS alone to decompress all the gastric varices?
So only tips will do, sir, but again I will go with BRTO, then after the tips.
So you do TIPS first and then do BRTO.
Yeah.
Dr. Sudhir?
So here patient's active bleed we have managed, the index bleed have been managed. Now patient have extensive varices in the posterior wall of the stomach, so they have high chances of rebleed. So we should consider secondary prophylaxis for gastric variceal. We have options in form of BRTO or TIPS plus antegrade obliteration of gastric varices. TIPS if we do alone, there is worsening chances of development of hepatic encephalopathy. So I would go for TIPS with antegrade obliteration of gastric varices.
So you want to combine both the procedures together, but we are clear on one thing, that we want to obliterate the gastric varices here. A TIPS alone may not be sufficient to take care of the gastric variceal bleed, even if you are able to achieve the TIPS patency.
Right, sir.
Dr. Sagnik, would ascites affect your decision making here?
Yes, so the presence of ascites would definitely make an impact. So for your first question, definitely a TIPS plus BETO would be the procedure of choice. But BRTO itself can be a follow-up, but considering that there are high-risk varices, there is a 30% risk of bleeding from EVs on follow-up. In the presence of ascites, again, TIPS would probably be the procedure of choice, followed by US coil.
That's perfect. So what we need to remember is, once you do a BRTO, you are actually increasing the portal vein pressure. The esophageal varices, which are already high risk, they may not have bled. Even when you are banding them, the risk of esophageal variceal bleed increases. When you do a BRTO for an isolated gastric varix, when the patient does not have esophageal varices, they tend to develop esophageal varices in the follow-up. So you have to do a procedure where you take care of both the esophageal varices and gastric varices. Doing two procedures may not be an ideal thing to do. So we would combine a TIPS with an antegrade obliteration. It may be a BATO, it may be a plug assisted, whichever way you want to handle that. That's for the radiologist to decide, but that's what we did. One particular scenario where BRTO is not possible is, so see, this is a cartoon to show you that usually 80% of patients who have gastric varices do have a gastrorenal shunt, but 20% may not have a gastrorenal shunt where BRTO becomes not applicable. There you do anywhere TIPS plus antegrade embolization. Case 2. So we've heard, I think we had an institutional debate about use of PLEX and CRRT versus transplant in ALF. I thought let's see what the audience thinks, how to manage their ALFs. So garden variety acute liver failure, HAV related. At presentation, bilirubin is 18, INR is 4.2, lactate of 4.5, grade 3 encephalopathy. Arterial ammonia is 181 and jaundice H is 5 days. So out of 5 King's College criteria, 3 are meeting. That means this patient merits, according to King's College criteria, a transplant. So first question to audience, how many of you follow King's College criteria for transplant in ALF? Quite a few actually. So let's go back to Dr. Manas. Dr. Manas, what are your comments on King's College criteria for transplant in ALF in Indian setting?
So in Indian setting, we have a good experience with HAV related acute liver failure. We can tide over with this conventional management like
No, sorry. The question is, do you believe in King's College criteria for acute liver failure in Indian setting?
Indian setting, no.
No. So for all the people who voted, they are following King's College. I just want to highlight that there is enough literature to say that even a INR of 6.5, more than 6.5 is not sacrosanct for a transplant in ALF in A and E hepatitis. Even when it is more than 7, we have patients who would respond to clinical management, and by day 2, day 3, they would start improving on conservative management. We'll come to management subsequently. This is what we follow. Dr. Acharya, I guess, is here. Dr. Acharya gave us this beautiful model. You prepare the patient for transplant, see the LFAT score at 48 hours, and then take a call. I would urge all of you to go back and read this, and those who are following King's College, just do this simultaneously with that, and you'll see the advantage of this model. Okay, so now we come to management. Again, we have an audience poll. What would you offer the transplant? The patient is meeting 3 criteria out of 5 of ALF according to King's College. Would you offer a transplant straight away? Would you give a PLEX? Would you do CRRT? Would you do CRRT plus PLEX? Or you'll just do conservative management without transplant? Yeah. It's equally divided house. So except the standard of care, everybody has their own say. Let me come to the experts. Dr. Mallikarjun, what would you do first in this case?
The patient will be prepared for the transplant and simultaneously start with the PLEX.
You would start with PLEX.
And
Dr. Sagnik?
So probably prepare for transplant and go ahead with CRRT.
CRRT. So we have a difference of opinion among the panelists here. Sudhir, please elucidate what would you do and why?
Sir, same with Dr. Sagnik. Patient has to be prepared for liver transplant. Team has to be ready for transplant if patient worsen. But as patient has hyperammonemia, patient's ammonia is more than 150, which is indirect marker of raised intracranial hypertension. So patient should be started on CRRT.
Okay, great. So Dr. Manas, so two with CRRT, 1 with PLEX.
So again CRRT?
CRRT. So we have hands down winner as CRRT here. I'm not saying what is the literature, you already have heard the debate. CRRT has been shown to be very effective in many of these patients, especially in those with hyperammonemia and higher grade of encephalopathy, and it does give you breathing time. But the most important thing which all our panelists highlighted is counsel the patient for transplant right at the outset. Why? Because you don't know which of these patients are going to improve, which are not. You will need 48 hours to 72 hours to prepare the patient for transplant, get all the workup done for the donor, get the committee prepared. Probably if you do it on a war footing, you will be able to do it in 36 to 48 hours. And that is the time you require to use your model, which I have shown you, to say whether the patient is improving or not improving. So we would counsel the patient for transplant at the outset, start CRRT. This patient did improve on CRRT and went back home without a transplant, but that's not to say that everybody would do that. So as of now, the house is for CRRT over Plex, but I'll leave to your imagination. Case 3. This is following up on the previous 2 sessions where all the radiology and endosono experts told us what to do. This is a 59-year-old female, cryptogenic cirrhosis, MELD score of 12. Last 1 year, the patient has been admitted 5 times for hepatic encephalopathy. Each time went home fine. The relatives tell us that the patient has turned very slow in the responses in general. There is no ascites, there is no upper GI bleed, there is no sepsis. MELD of 12 means patient has slightly high bilirubin and some prolonged prothrombin time because the creatinine was normal. So as we do in all patients, we did a CECT triple phase. Patient has cirrhosis. There is no SOL, no ascites. There are 2 large shunts. One is a splenorenal shunt, another is a mesocaval shunt between the SMV and IVC. Let's ask the audience what they would do. Would you continue or intensify your medical management? Maybe you will add LOLA, maybe you will add branch chain amino acids in addition to lactulose rifaximin. Would you do a shunt embolization or occlusion? Would you ask for a surgical shunt? Or would you ask for a transplant here? MELD is 12, please remember. So it does come in the borderline category. So most people want shunt embolization. So that's good. Let's start with Dr. Manas this time. What is your opinion on this?
I will go with shunt embolization again first, because of course this patient may require liver transplantation later on, but at this stage I will go for shunt embolization.
So would you have any special considerations or circumstances where you would not do a shunt in such a scenario, or would you go, see this guy has a MELD of 12. There is no ascites, obviously 2 large shunt patient will not have ascites. The bilirubin is less than 3.5. INR is around 1.7, 1.6, which comes to a MELD score of around 12, 13. That's where we are standing. So the moment so the first question is, would you block both the shunts? Will you block one shunt? Let's say both shunts are contributing equally according to the Dopplers which our radiologists tell us. So would you block one shunt and be happy about it, to block both? And would you be worried that the liver function may deteriorate because you're increasing actually portal hypertension, you're increasing the flow to the liver. The jaundice may worsen, the ascites may appear. So Dr. Sudhir, please.
So at present patient is having recurrent bout of HE because of the shunts only. So we will block both the stent because MELD score is at present less than 15, that is 12 only. But we should be ready because these patients can have increased portal hypertension. 1/3 of the patient can develop ascites. So these patients can worsen, and for that we need to do further therapies for them.
Great. Dr. Mallikarjun?
I think we can wait here, like as you said, we can shunt one part of and wait and watch and see if patient is, because we have already, there is not like, there is nothing emergency in this patient. We can wait and watch, and you can take up subsequently if the patient is persistent HE.
Dr. Sagnik?
So he meets the criteria for shunt embolization, 5 episodes. And
one shunt, 2 shunt.
Probably one shunt, splenorenal first and then.
So we have a completely divided house, 2 people. So all of us agree that shunt occlusion should be done. 2 of our panelists say both shunt should be ligated, 2 say that one shunt should be ligated. There is no answer to this. What we need to remember is a patient has come to you with encephalopathy. You block one shunt, the other shunt may increase. The patient may still continue to have encephalopathy. Then you offer one more procedure after that. So it's on individual choice, but shunt occlusion is the way to go forward. What we did was, this is a linearenal shunt, the splenorenal shunt. We used plug device to block it. This was the other shunt. The mesocaval shunt between SMV and IVC, we blocked that also. So we decided for both the shunt blockade, but again, there's no literature to say whether to block one or not. Here, you want to give a complete treatment option to the patient. You don't want encephalopathy to happen again. But please remember what I said in the first case. The moment you block the shunts, the growth of esophageal gastric varices does increase, and the patients are at recurrent risk of bleeding. You also have to do endoscopy to see what is the varices status. You might need to band the varices now or later. So please remember, whatever you decide, do remember ascites will develop, patient will require diuretics, and patient is likely to require banding straight away. If the patient does not have varices, the varices will develop. Let's move on to the fourth case. We have 5 minutes left for this. 58-year-old male patient, alcoholic liver disease, MEL score of 24, comes with altered sensorium for 2 days. At presentation, serum sodium is 124, patient has AKI HRS, creatinine is 2.5. The patient was admitted in ICU, started on terlipressin albumin. The creatinine did improve to 1.2 from 2.5 on day 3 of admission, but sodium actually was falling, and the patient continued to be in grade 3 encephalopathy. So what would the audience do? The options are, you restrict IV fluids, continue terli albumin, the patient is, mind you, responding, his HRS is responding. Second option, add furosemide to terli albumin. Third, add 3% saline to bring up the sodium. Fourth, start tolvaptan. So no takers for saline or tolvaptan, and we have equally divided house between furosemide and terli albumin. Now let's hear the expert. This is something very interesting. So let's start with Dr. Sagnik this time. Dr. Sagnik, what would you do? Would you consider tolvaptan? Would you give 3% saline? Or would you just continue conservative management?
So restrict IV fluids, terli and albumin.
Okay, so we restricted IV fluids, the sodium did not improve. Now what do you do?
Probably move on to adding furosemide. We'll give a Lasix challenge.
Lasix. So you will not straight away want to give Lasix. You want to first try restrict IV fluids.
Yes.
Dr. Mallikarjun?
Yeah, I will we'll follow the restricting IV fluid, continue terli albumin and see the response and take the call. But tolvaptan is little bit because patient is in grade 3 encephalopathy, I think. And other aspirin, yes, 3% saline may not help.
Okay.
I think first option will not continue.
Dr. Sudhir?
Sir, I agree with two of my panelists. But if patient is in high MELD score, patient is planned for liver transplant, so then we can consider tolvaptan for short durations to stabilize the sodium level of around 130 or so. Otherwise, I agree with the other panelists.
Manas?
Option 1, sir.
Option 1. Okay. So Sudhir might consider tolvaptan if the patient is listed for transplant. So patient actually is listed for transplant. Let's say patient is listed. If you decide to give tolvaptan in such a case, what dose? How long you have already answered? A short spurt of time till the sodium comes above 130 when you want to transplant. So what dose would you start with? We have a 15 milligram tablet, we have a 7.5 milligram tablet available.
So starting with low dose like 15 milligram and see the response and monitor the side effect of tolvaptan like dehydration, hypotension, acute kidney injury, and how long it should be for short duration, less than 30 days.
Okay, so let's change the scenario a bit. Anybody in the house who wants to give tolvaptan or has experience with tolvaptan in a pre-transplant setting? Neeraj, you want to comment on that?
I would use tolvaptan, probably start with 7.5.
So we are even more conservative. If we have to use tolvaptan, we have very few scenarios where we use. One is pre-transplant, we start with 3.75. Even 7.5 we consider is quite high a dose. But please remember that somebody who has a AKI, the likelihood of tolvaptan acting is very low. So with a normal creatinine, tolvaptan works very well. It actually can cause sudden diuresis and sodiums can go up to 140 also. In an impaired renal function, it works less often. Any other indication, a patient is chronic hyponatremic, chronically hyponatremic, would you consider in that? Or there is some literature, some Japanese literature from Korea also to suggest that in case you have an inadequate response of ascites to spironolactone and loop diuretic, would you like adding or would you consider adding a small dose of tolvaptan? Anybody from the panel, if you have experience?
Yeah, we do use in long-term maintenance like 15 days to a month I have been using, and some patients have shown good response.
Okay, so we have last 1 minute left. I have no conclusion slides here. So tolvaptan, I wanted to highlight a few things. That's the reason we took up this case. It's a double-edged sword. It works. It may overwork also. The only two scenarios where we use a Vaptan is one in a in a refractory ascites where there's an inadequate response. Nowadays we have midodrine also. So let's say somebody who has inadequate response to all three, we might consider adding tolvaptan, and we always start at a very small dose, 1/4 of the dose, 3.75, and try to build it up. Secondly, pre-transplant is a more common setting where we use it. Again, we start at 3.75, go up to maximum of 15 for a short period of time, till the time you get the patient ready for this thing. So tolvaptan is notorious to cause AKI, especially in patients who already have some AKI going on or who are on diuretics. Tolvaptan also can cause sudden diuresis that patient can go into dehydration and further hypotension. So please be careful, but in specific setting it can be used. I thank you for your patience.
Thank you everyone. Now I'd like to request all of you to come forward for a photograph near the photo. Moving on to our last session on viral hepatitis, I'd like to call our moderators, Dr. Sandeep Pandey, Dr. Ajay Bhalla on the left side of the panel, and expert discussants, Dr. Rahul Jain, Dr. Vaishali Bharadwaj, Dr. Manoj K. Sharma. Our speaker for the session is Dr. Anil Arora, who will be speaking on simplifying management in chronic hepatitis B, MASLD, adding to the confusion.
Good morning to you all, and thanks Neeraj and the team for giving me this opportunity. So rather than giving you a detailed outline of how to treat hepatitis B, especially to this August gathering, I have switched gears and I'm just going to talk of something specific which possibly Neeraj had in his mind, the interaction, the unholy or holy interaction between the fatty liver disease and hepatitis B. All of us know that today we have very little to offer in terms of treatment of hepatitis B other than a single tablet called TAF, which more often than not is restricted for no reasons. So I'll take the permission of Neeraj to just talk of interaction between hepatitis B and NAFLD rather than giving you the mundane guidelines of giving one tablet. Now, hepatitis B virus infection and non-alcoholic fatty liver disease is not an uncommon scenario. Especially if you talk of places, geographical regions like Asia Pacific, where hepatitis B is one of the predominant causes of the liver disease, and all over the world, NAFLD is coming as a burgeoning problem because of the increasing prevalence overall. Now, this is the data published recently. There are about 250 million carriers of hepatitis B, and after the advent of the vaccine for hepatitis B, the use of antiviral drugs and interferon, there has been substantial drops, at least in the western world, of incidence and prevalence of hepatitis B. But at the same time, if you look at the geographical patterns of the food consumption, there has been a rapid increase in prevalence and the incidence of non-alcoholic fatty liver disease. So as of today, it has become one of the commonest causes of the liver disease which is being faced by day-to-day practicing gastroenterologists and hepatologists. So we have 25% patients of liver disease which are attributed to be because of the non-alcoholic fatty liver disease. There is also data to show what is the subgroup of the patient which will have concomitant hepatitis B as well as NAFLD. This is the subgroup of the patient which will have contentious issues in management and the various interaction between hepatitis B and alcoholic and non-alcoholic fatty liver disease. It has been repeatedly shown over a period of time in prospective cohort studies that overall the patients, about 1/3 of the patients with NAFLD may have concomitant hepatitis B, at least in the Chinese studies. And in meta-analysis by Zhang et al. Recently analyzed 53 studies and convincingly showed that the incidence of non-alcoholic fatty liver disease in chronic hepatitis B was to the tune of about 32%. That means patients with hepatitis B are very likely to have an underlying hepatitis B. What is the interaction between the hepatitis B and NAFLD? Most studies suggest that hepatitis B infection may reduce the incidence of NAFLD. This was surprising to me when I was just reviewing the literature, because there is a direct correlation between HBV infection and the degree of hypercholesterolemia, both LDL and non-HDL hypercholesterolemia. In fact, higher the replication of hepatitis B, the lesser will be the occurrence of fatty liver disease. So by default, hepatitis B tends to decrease the accumulation of the fat in the liver. At the same time, NAFLD can promote the spontaneous clearance of hepatitis B virus. This is something which is another important issue to realize, that NAFLD accelerates the clearance of hepatitis B. That is because by default, most of the patients with NAFLD who are switching on to NASH have stimulation of the inflammatory cascade, especially because of the transfer of the LPS across the leaky gut membrane. And this enhanced immunity somehow tends to get rid of hepatitis B virus. So if you have NAFLD going on to NASH, you are likely to clear hepatitis B spontaneously. But at the same time, look at the contradiction. If you have an NAFLD coupled with hepatitis B, you are more likely to have advanced liver disease. And the reason that you have increased immunity, that is making an attempt to clear the virus. So there are different mechanistic role and pathways which talk of, in patient with NAFLD, what is the effect of HBV infection in terms of the progression of the disease and development of hepatocellular carcinoma. In general, most of the patients with NAFLD, especially if they are having progression, will have more stimulation of TLRs as well as increased immune reactivation and restitution. So this immune activation and restitution in patient with NAFLD switching on to NASH is likely to cause inhibition of the replication and try to increase the antiviral response to the immune system. Because all of us know the reason hepatitis B is persisting in the body is that you have a poor response, which is not good enough to mount itself to a stage where it should be getting rid of hepatitis B. So with increasing immune response, you are more likely to clear the virus. But even if you are clearing the virus, if you see most of the patients who have concomitant competing pathology of fatty liver as well as hepatitis B are still likely to progress to cirrhosis and development of hepatocellular carcinoma. What is the effect of hepatitis B on NAFLD? Let's try to change the gears. Now, in a patient who has HBV, the various components of HBV structure in the form of core antigen, E antigen, X antigen, they are known to decrease the production of the cholesterol and its metabolites within the liver. So overall, the hepatic metabolism of the glucose and lipid is altered, and the prevalence of fatty liver disease decreases. So even when hepatitis B is trying to decrease the deposition of the fat in the liver by decreasing the synthesis of the lipogenic moieties as well as increasing the beta oxidation, still there is a progressive damage to the liver because of the concomitant pathology. It has been known that overall hepatitis B will have some neutralizing effect on the lipid metabolism because it is known to activate the expression of some key lipid and cholesterol production related proteins and also tends to upregulate the beta oxidation of the fatty acids. So if you have hepatitis B, so it is going to decrease the fat in the liver by both decreasing the production of the fatty acid, by decreasing the sterol regulatory retinol binding protein, as well as increasing the beta oxidation of the fatty acids. In fact, these are the various studies which have been published primarily from China, which have looked at the effect of NAFLD on HBV infected patient. Mild steatosis somehow does not have any significant relevance, but if you have moderate to severe steatosis, so this is a subgroup of the patient in which you are more likely to have HBsAg clearance or HBsAg removal from the body. And most of these patients suggest that NAFLD is a favorable factor for spontaneous clearance of HBsAg. But we do not know whether this viral clearance does translate into an overall better outcome in this subgroup of the patient who have both pathologies. So if you look at the literature of NAFLD and antiviral treatment, there have been contradictory findings. So there are studies which have shown that overall, if you are using entecavir for treatment of hepatitis B in patient with non-alcoholic fatty liver disease, the overall efficacy is less. It is much better if you are using TDF or tenofovir. But if you are using a drug called TAF, which is the drug of choice for today's management of hepatitis B, TAF is known to have dyslipidemias and is likely to increase the deposition of the fat in the liver. In fact, there are a lot of contradictory findings of the when you discuss the relevance of antiviral therapy in patients with hepatitis B. So these are the various studies which have looked at the efficacy of antiviral therapy in patients with non-alcoholic fatty liver disease who are being treated with hepatitis B. And most of these studies have shown that if you are giving entecavir, your chance of clearance of hepatitis B will be less. If you are giving TDF, there is no effect, and if you are giving TAF, you are more likely to have dyslipidemia which is occurring. So these studies have looked at the impact of antiviral drugs on hepatic steatosis. Overall, it has been shown that nucleic acid analogs, there is hardly any difference between all three drugs, but suffice it to say that the anticavir treatment is likely to have less efficacy in clearance as compared to TDF. So if you have to choose one drug in NAFLD, then TDF is a better drug, whereas in TAF, it is known to cause dyslipidemia and weight gain. And then it is recommended that any patient who has a NAFLD coupled with hepatitis B, you should be more carefully or more closely monitoring the lipids which will have deleterious effects. So in a given scenario in which you have two competing pathologies which are giving you the same problem of progressive fibrosis, inflammation and development of the end-stage liver disease coupled with occurrence of HCC, there are other confounding factors which may not be discernible in these studies. These include genetic factors, viral factors and the metabolic factors like insulin resistance, obesity and dyslipidemia, which could be aggravating the injury to the liver at the same time, independent of the effect of the hepatitis B or the virus. In fact, it has been shown and repeatedly discussed in our hepatology forums that if a patient has an incidental HBsAg with NAFLD and has raised ALT, how do you know whether this raised ALT is because of HBsAg or is it because of the non-alcoholic fatty liver disease? There is no way. Patient may have slight rise in HBV DNA. In fact, there is one study which has looked at the evaluation of liver biopsy in such subgroup of the patient. In fact, this clearly shows that if you have a more of ground glass appearance and portal inflammation, then the raised enzymes are more likely to be because of hepatitis B. If the problem is primarily focused in the perivenular region or in the form of more presence of the lipid droplets, then possibly NAFLD is the cause of persistent hypertransamininemia. But then if you look at the statistical analysis, this may not be variable. This is another way of looking at the effect of hepatic steatosis on the progression of the liver fibrosis in chronic hepatitis B. And it has been shown, if you look at the odds ratio in various studies, it's pretty variable. But overall, it clearly shows that the fact that you have fatty liver in patient with hepatitis B, your odds ratio is to the tune of about 1.5 to 2. That means you have 2 times more chance of developing progressive liver disease in the form of either end-stage liver disease or hepatocellular carcinoma. In fact, when you talk of this interaction between fatty liver disease and hepatitis B, we should understand that a number of genetic factors, viral factors, metabolic factors, and ongoing inflammation because of this, they collide in such a manner that to dissect out the relevance of each individual component may not be easy. And these are the various attempts which have been made to look at incidence of development of hepatocellular carcinoma in patients who have both concomitant NAFLD as well as hepatitis B. And if you look at again at the various studies and the odds ratios, the odd ratios varies from anywhere between 0.21 to 1.67. In fact, the occurrence of increased incidence of HCC is very controversial. There are studies which show that incidence of HCC is less because hepatitis B decreases development of the fat, and once you have fat, it causes spontaneous clearance of hepatitis B. So there is a lot of controversy which is still not settled. So the key consideration for clinical management of hepatitis B in patients are that you have to screen these patients and give a close attention to the presence of the fat in the liver. Drug interaction may has to be seen, but there is some data to suggest that especially TAF is known to increase the dyslipidemia, and in patients with NAFLD, dyslipidemia and coronary events are a major cause of mortality, and you have to at the same time assess their cardiovascular risk. To sum up, ladies and gentlemen, HBV infection in combination with NAFLD is very common. As per the literature, every third patient will have a combination of the two. Most current studies do suggest that the HBV infection reduces the incidence of NAFLD, which may be related to the negative regulatory role of HBV in lipid metabolism by increasing the beta oxidation as well as trying to suppress the formation of the fatty acids. NAFLD can promote the spontaneous clearance of the HBsAg, but we are not sure whether it relates to increase in the survival or increase in the overall outcome of the end stage problem related to the chronic liver disease. The intrinsic mechanism of spontaneous clearance of HbSAg in NAFLD may be related to transmigration of the LPS across the leaky gut membrane and stimulation of the TLR, which by default increase the innate and adaptive immunity in patients of hepatitis B who typically have low immune system. The effect of steatosis on antiviral efficacy has been reported inconsistently. TDF has a lipid lowering effect, whereas TAF may cause dyslipidemia. This may be a food for thought in patients with the fatty liver disease coupled with hepatitis B. If you have to choose the drug, maybe this is one of the rare indications in which you may prefer TDF over TAF. Majority of the studies demonstrated steatosis contributes to the progression of the liver fibrosis. However, the outcome of HB infection in patients with NAFLD in its relationship with progression of the HCC is still controversial because the odd ratio have varied in various studies from 0.1 to 2, which doesn't take you anywhere. Thank you.
Thank you, sir. We have the Q&A at the end of the session. We'd like to request you to take a seat at the right hand of the dais. We have a very interesting session next on viral hepatitis. The session has two small cases. Considering the new changing epidemiology of hepatitis A, we thought we would discuss hepatitis A in its new avatar. And for that, I would like to call the panelists, Dr. Rahul Rai, Dr. Abhishek Kathuria, Dr. Shubham Mehta, and Dr. Arkade to take their seats on the panel, on the center of the dais. And for the first case, I would like to call Dr. Ashish Singh. He will be discussing a case of hepatitis A related acute liver failure. Dr. Ashish.
Good afternoon, everybody. I will thank Anand sir and Manav sir to make my case easy because already many things have been discussed. So in the next 10 minutes or so, I will discuss a case that we usually see daily now with the increasing prevalence. So it is a case of 19-year-old male, BMI of 25.6, presented with loss of appetite for 6 days, jaundice, vomiting, fever for the last 6 days, and history of altered sensorium since the last 1 day. He came with casualty with the pulse rate of 112, PP of 108/60, respiratory of 24, were febrile, and SpO2 of 94%. So the investigation done in the emergency department revealed ammonia of 119, INR of 2.1, bilirubin of direct of 8.9, HGOTP in the thousands, creatinine of 1.9. Etiological workup found to have positive for IgM HAV, rest of the workup were negative. We also ruled out the ALF mimics, was negative for scrub, malaria, lepto. Procal was on the higher side, 6.39, USG showing grade 2 fatty liver, and CT brain was showing sign of cerebral edema. So diagnosis of hyperacute ALF, HAV related. So the question for audience, in your clinical practice, what is the most common etiology of ALF that you are seeing? So rightly said, HAV. So if we see the previous data published in NEGM, the predominantly the West was showing the drug-induced, paracetamol-induced, and the India, the predominant was HEV with cryptogenic around 31% and HAV only 2%. There is stark difference between the ALF etiology between the East and the West, with the drug predominantly in the US, UK, and in India it was E predominantly. That was the data published in 2013. Now there are several series that has shown the etiological agent, with the trend has been changing from the HEV and more towards the HAV, with some series showing around 40% of the cases because of the HAV-LF. So my question to Rahul sir, what can be the causes of these changing trends in the HAV infection?
What is happening is in most of the parts of India that the level of hygiene is, I think, better picking up, and migration towards the cities is also taking place. So seroprevalence of hepatitis A in childhood is decreasing. So earlier it was to the tune of 90%. And then probably the vaccination is not also taking properly because it has not been into the universal immunization program. It's an optional thing. So I think because of that, the epidemiology is changing and more adults are now being susceptible to this hepatitis A infection, and probably most post-COVID area also, they are more having chances of having a severe disease. So I think that can be one of the reasons.
Right, this is sir. So there is a paradox of HIV epidemiology. In areas with high epidemiology, children are often affected in the early age, leading to the widespread immunity or mild or asymptomatic disease.
Can I have a question here?
Yes, sir.
And if it's question of hygiene, so do we have a data that this affects primarily the people who are in the upper echelons of society versus those in the lower echelon, or else then why not E also? Delhi is not hygienic at all. So is it something to do, because we hardly see hepatitis E now,
Yeah.
it's all replaced by hepatitis E. Either hepatitis E has mutated or A has mutated, because hygiene has not improved.
Yeah, so I think so there's no data actually whether it is more in urban or a rural population. That's just a speculation why this is changing. As far as E is concerned, sir, I think the amount of hepatitis E patients, they remain the same, but because of E which has progressed, the contribution of E seems to be little less. So that can be one of the explanations.
But I'll differ. If you see at Gangaram, we used to see a ratio of about 60 to, most of the adults by default will be having E and most of the children will have A. But in adults, 95% have A. So this is the top echelon of the society who have never been exposed in the childhood.
So,
I think the clinical feature have also changed. Basically, the hepatitis A virus now, basically, fever is still persisting if jaundice appeared.
So prolonged jaundice, prolonged cholestasis, these are the new. So is it the changing pattern of the, maybe virus has mutated, or maybe hepatitis E has got attenuated?
Or maybe see, once infected hepatitis A, it confers usually a lifelong immunity, but that might not be same in the case of hepatitis C. We see that the IgM, the IgG levels, they decrease over the times in hepatitis E. So that can be one of the explanations, but I think more has to be studied.
There could be some virological factors, obviously, because even if we talk to the pediatricians, we see that the ALFs that they are getting is much more severe. So why is it that previously it was? So could be some virological thing. What we have seen, we have a lot of biopsies in these hepatitis A patients. This is not the ALF variety, but the patients who present with prolonged cholestasis. And invariably, all of them have got a lot of bile duct injury. So we don't have, obviously, hepatitis A biopsy series reported recently, but if you look at the 1980s data and all those, very few patients had cholestasis, but in them the biopsies it was planned cholestasis. There was no real bile duct injury going on. Why is this occurring? Is there a genotypic change? I think there is some data from Kerala at least that the genotype 3 is still common. That is what was common even previously. In PJ, we have been screening our healthcare workers, the faculty, the residents, etc. Among the residents so far, what has been screened, around 200 patients, 98% of them do not have neither hepatitis A nor hepatitis E IgG antibodies. Among the faculty members, I don't have all the data, but among the professors particularly, practically all of them are IgG positive for hepatitis E.
Because in adult practice, at least in our hospital, occurrence of hepatitis E as an acute infection is as elusive as Virat Kohli's centuries in cricket. So it becomes so uncommon.
It is quite possible that the age of contracting HIV is increasing. So you are seeing more severe patients. So they are on the forefront.
Just a point. Children with hepatitis A still have a very mild disease. So I don't think the virus has changed. It's just that it started affecting a different age group. You still see a lot of asymptomatic children with HIV who come in. So I guess it's not the virus which has changed. It's only the presentation in the grown-ups which is causing a problem.
Actually, sir, there is a data in which they have shown that the people with the higher socioeconomic group, around 20 to 30 age group, are higher prone to develop HIV as compared to other. Coming back to case, so the patient was admitted, started on supportive treatment. On the day 3, the TLC was elevated, ammonia amount to 153, INR to 3.82, worsening of bilirubin level. The creatinine jumped from 1.9 to 2.4. Procal was 11. There was worsening of hepatic encephalopathy and patient was intubated for airway protection. The prognostic scores of MELDOT 39, dynamic alpha was 4, and the patient doesn't fulfill the King's College criteria for non-paroxysmal ALF. So question about the audience, will you consider listing patient for urgent liver transplant? Can I have the audience poll, please? So most of the people said no. So my question to Sora is, what are the different prognostic scores or any specific criteria score for you for HLF?
Thank you. So the different prognostic scores that I'm aware of include ALFED, MELD, and King's Croix criteria. As far as Indian settings are concerned, especially in the non-paracetamol setting, for us, dynamic scores, ALFED score would be the best suited to gauge the severity and the in-hospital mortality in this particular case. So as for our patients, since on day 3, the patient had encephalopathy, the INR is, and the ALFED score is 4, I would consider listing this patient for transplant.
Rightly, sir. We also followed ALFED score in this patient. Have shown good ROC as compared to the other organ failure scores. But there are 2 other scores, ALF-SG index for HAV, that incorporate factors such as creatinine, ALT level, the patient of ventilation support, and need for pressure. Similarly, the alpha score has a look at the HIV prognostic model in adults, but yes, ALFED is the score we go by. So patient was fulfilled ALFED score, but another issue was that he had AKI. So my question to Arka sir will be like transplant or patient of ALF with AKI, with both setting, oligoric and non-oligoric.
Volume dependent is usually a pre-renal kind of thing. So I mean, we will have to correct the volume status and stabilize the renal function as well as possible, and then take up the patient for liver transplant. Not really an SLKT over here. In SLKT, the duration of dialysis, etc., for more than 6 weeks. So I mean, over here, we would, as far as possible, correct the volume status and everything, and then take it down.
Right, sir, we have to correct the underlying causes, inflammation, tissue hypoxemia, DAMPs. There is a series which has, most of the retrospective series that has shown that rising creatinine usually affect the worsening post-transplant as well as in the downward course. Also, there are other modalities that can prevent by renoprotective measure or by CRRT, we come to later. And AKI in ALF definitely has impact on the survival after liver transplant. So this patient was counseled regarding the LT, however no suitable donor could be identified. So this is the patient who is sick, has worsening renal parameter, there is no donor availability. So my question will be to Abhishek sir, how will you proceed? What are the role of therapies such as PLEX in this group of patient?
So definitely one can consider PLEX in such a scenario, because in acute liver failure, this was a very important study published by Larson et al. In 2016, where they have recommended that high volume plasma exchange was beneficial for patients without transplant, and the survival was better as compared to the standard medical therapy. Second important thing is that during their later publication, they have also found out that volume, since there was a lot of discrepancy in the etiology, they have suggested that low volume plasma exchange is equally beneficial, and in fact it's more beneficial that it reduces the chances of circulatory overload.
So correctly said, whether it is high, standard or low, definitely they have shown some benefit in the treatment of ALF, with the American Society has recommended as a class 1 indication. However, there was a recent paper in the European subset that has shown that PLEX may not improve the overall survival. However, there may be discrepancy between the paper used and what the cohort they have used. So continuing the case, he developed high grade of fever, antibiotic was escalated, he developed hypotension, vasopressor. So we couldn't do PLEX, so persistence of HE, decreased urine output, we done the CT showing bilateral patches pneumonia. So my question will be, Arka sir, will be what is the role of in this patient CRT, and how will we say whether we can compare CRT with the X or we want to just both concomitant therapy?
So with respect to CRRT, we have this retrospective study by the ALF-SG, the ALF study group in 2018, where it was shown, they compared intermittent renal replacement therapy versus CRRT versus no renal replacement therapy, and intermittent renal replacement therapy actually had worse outcomes as compared to SMT, but CRRT, it not only decreased the ammonia levels, but it also improved the 21-day survival. As far as I am aware, I don't think so we have any other data on CRRT, published data, unlike PLEX. But since this patient is hemodynamically unstable, he has got AKI, I think in this patient CRRT would be a better modality than PLEX. He would never tolerate PLEX.
I have a small query. See, this is a patient who had AKI in addition, which would mean that he had an advanced, over and above the liver disease, there was a secondary effect on the other organs. So rather than contemplating transplantation from the very beginning, could he have benefited from the PLEX, because it will take away of all things like cytotoxins and other dams, PAMs. It gives you some more breathing space to go in for it. Otherwise, he has a progressive downhill course. So more often than not, you cannot correct all the factors which you had mentioned. So if you can correct, then that means you are correcting the liver. So maybe PLEX at early antedating PLEX could have been better.
Preemptive PLEX search would have been possible, but the patient was in shock. So there was drop in blood pressure level. So doing the PLEX would cause the flux flow and may worsen the pressure status in this patient. So we initially planned for PLEX, but because of that, we go ahead with the CRRT in this group patient. So the meta-analysis also showing the CRRT has a lowering ammonia lowering effect, and that leads to the better survival. As rightly pointed out, sir, PLEX also help in reducing ammonia. They have direct removal of ammonia in the discard plasma, can help in treating the primary element in the liver, and can help the improvement in patient. So patient was continued on CRRT. There was reduction in mechanical ventilator support, improvement in renal parameter. Patient eventually got out of the ICU, extubated, low-grade fever. Patient has persistent cholestasis with the AKI. I was in the hospital for at least 21 days. Has required 2 more sessions of dialysis, and has been discharged, and as a follow-up. I'm not going ahead to the cholestasis part because it will be discussed in the next case. So overall, the current etiology of outcome of ALF is improving, better survival. Children, as sir pointed out, more better survival. In our experience, in the last 3 years, we have got 52 years of ALF, median age of 22, with 88% have more than grade 2 encephalopathy, 44 has AKI, and we achieved 96% survival with 92% transplant-free survival. Thank you.
Thank you, Ashish. I request you to take your seat in the audience, and we will have the discussion at the end. The next case will be presented by Dr. Jaswin Dhingra. He would be speaking on hepatitis A-related acute liver injury with prolonged cholestasis.
Thank you. I bring you all greetings from AGI Ludhiana. So I'll be discussing this interesting case. We had a 26-year-old male with no comorbidities who presented to us with complaints of progressive jaundice since last 2 months, intense itching since last 1 month, and had a history of decreased appetite and weight loss of 8 to 10 kgs over these last 2 months. Clinically, he was deeply ecteric. He had infected scratch marks on entire axilla and limbs. There was no HE. He had a palpable hepatomegaly. So we worked up this patient. At initial presentation, the INR was fine. Bilirubin was very high of 38 with a direct component of 31. SGOT-PT were mildly elevated, high ALP, high GGT. Renal functions were fine. His ammonia was fine. The hemolytic workup was okay. IgM anti-HAV was positive. Ultrasound showed a hepatosplenomegaly with no IHPRD. So the diagnosis was quite straightforward. It was an acute HAV hepatitis with prolonged cholestatic jaundice. So my question to the first panelist, Dr. Rahul, how do you define this prolonged cholestatic jaundice, and how common is it in viral hepatitis?
See, most of the patients who have acute hepatitis A, so initially most of these patients will have some amount of cholestasis. But after at some point of time during the course of illness, they can have again increasing, say, bilirubin, more of itching, and again recurrence of clay-colored stools. So then we call them as prolonged cholestatic phase. The duration can be, say, about 8 weeks or 12 weeks, around 3 months. So I think those patients who were having cholestatic symptoms and liver enzyme showing increased amount of AST and GGT, and the duration for at least of, say, about 2.5 to 3 months. So I think those patients we can call it as cholestasis. As far as this chronic prolonged cholestatic jaundice is concerned in viral hepatitis, that is, I think, not very common. So about to the tune of about 5–10% we can have prolonged cholestatic jaundice in acute viral hepatitis A related.
Yes. So you are very right, sir. This term was coined with a definition of having a high serum bilirubin of more than 10 with a direct component of more than 50%. AST/ALT levels have to be less than 500 and a duration, as you pointed out, should be more than 8 to 12 weeks, and there should be absence of hemolysis and renal failure. And the incidence is, as rightly said, less than 5% in viral hepatitis. Now, the course of our patient was at the time of referral to our center, he was already on oral steroids. He had been taking tabvisolone 40 mg OD for last 7 days. He was on antihistaminics, he was on UDCA. He had been given NAC initially for 5 days IV and then it had been tapered. And he had taken all of these with absolutely no response either clinically or in his biochemical investigations. So we continued him on tapering dose of steroids. We added sertraline, added montelukast. I want to ask, what is the role of corticosteroids in prolonged cholestatic jaundice? Dr. Shubham, what should be the dose, duration, and how do we assess the response?
So, steroids are intended to target the immune-mediated cholestasis due to the molecular mimicry secondary to HIV infection. As far as I know, there are no dose-finding trials for the dose of corticosteroids in such patients based on case series and extrapolation from autoimmune hepatitis. 1 milligram per kg of Visolon would be a good dose to start with. The response assessment must be done based on the delta change in bilirubin and the liver enzymes, especially ALP in this patient over the due course of time. Again, there's limited data as to how to gauge the delta change, but extrapolating this from surface score in acute severe AIH, since this patient has no response by day 7, I don't think steroids would work in this patient over the long term. Duration, if the patient responds and if the patient shows a falling trend of bilirubin and liver enzymes, we can safely taper steroids in such patient. If there is no response, again, we can quickly taper and switch over to the next therapy.
Right. So the role of corticosteroids, because this is a entity which is very less in incidence, so in prolonged cholestatic jaundice, there was a short paper which compared 40 patients. So they did head-to-head comparison between steroids and UDCA, and they found in the dose of 0.75 to 1 mg per kg body weight, tapered 10 mg every weekly for a total duration of 4 weeks. That's a short course that they had defined. The mean time to resolution of pruritus was 20 days in steroids versus almost 35 days with UDCA, and mean time to clearance of jaundice was 36 days in steroids and almost 50 days in UDCA. So we have some guidance here. Now the primary concern of the patient is his pruritus is very severe, intractable, he has a poor appetite. His only concern is pruritus. So what are the medical management options for this severe intractable pruritus? Dr. Abhishek?
So as we all know that UDCA has already been used, antihistaminics in the form of hydroxyzine has been used. So these two steps were right and sertraline has been added. Other options which we have is naltrexone, which can be used, or cholestyramine. Important thing is we have to keep a 2-hour gap between cholestyramine and UDCA. So these are the things which need to be done. And in very severe cases, rifampicin can also be used. Exactly. So these are the oral agents which are available.
Yes.
So can I have a small query? How does antihistaminic act? Because it has to do everything with the retention of the bile. What does histamine to do with it?
So
sir,
very often it has been noticed that in such patients there is a high amount of 5-HT, so antihistaminics, they help in reducing them. So that's one of the mechanisms I have.
And is there a way of knowing that is it that this subgroup of the patient are likely to have certain genetic abnormalities of BSAP enzymes or MDR3, so they have a tendency to decrease the bile flow, which gets aggravated during, say, acute injury to the liver? Is there a study showing that?
Not sure, sir.
Not sure, sir.
So, as you rightly said, Dr. Abhishek, medical management of severe intractable pruritus based on receptors, so we can have a pyramidal approach with naltrexone being at the apex, but now with a good availability, we'll have to see how it works in such patients. Now the point is, we have exhausted all the medical management options. The steroids have not worked, antihistaminics, UDCA, sertraline, montelukast. There is no response. Neither there is any improvement in the LFT trend. How do we proceed? Dr. Arka?
Field, we would have to go ahead and decrease the bile acid levels by some measure. So, I mean, Plex there is obviously plasmapheresis could be done, and other options that have been tried include your nasobiliary drainage also, NBD can also. Just with respect to the medical management, one query I just wanted to ask the house. So we have these IBATs now, we have the intestinal bile acid transport inhibitor. So the IBATs that are actually approved for intrahepatic cholestasis, that is in PFA, Calogel, those are not available in India. We don't have maralixibat or devixibat like that. But we do have elovixibat, which is basically approved for chronic constipation. So I just wanted to know from the house if anybody has any or anybody has tried to use it maybe for intrahepatic cholestasis.
There is data. This point was discussed when we launched this drug called Bixibat, which is IBAT inhibitor. The amount of the bile salt which is altered during consumption of the IBAT is only 1% of the total bile acid, which is enough to give you enough osmotic load within the colon to produce diarrhea. It doesn't alter the intrahepatic circulation at all. That 1% is enough. That point was discussed.
So one more point, Dr. Arka, like you said, the NBDC, since it's more of a conjugation rather than a obstructive defect, I think that won't work here.
NBD is not biliary drainage. It is not putting a stent. If you put a stent, it will never work. But if you put an NBD, it could still work theoretically. It used to be done previously by many of our senior faculty members. I'd seen them during my residency. Now, since Plex has become so, we are not doing so much of NBD. So the principle would be you're exteriorizing the bile acid. So you're decreasing the enterohepatic circulation, and that decreases your bile acid.
Right.
I think a combination of steroid to begin with followed by Plex will almost always give you relief in the patient with an acute injury to the liver, which is going to settle down. You hardly have, it may get prolonged, it may be a nuisance, it may be troublesome for the patient, but I think just hold on, everybody will respond.
Yes, sir. So as rightly said, we proceeded with Plex. So we did some literature review on the role of Plex, specifically in intractable pruritus. So what studies we could get were in gynecology journals, few pediatric journals as with drug-induced cholestasis. But we proceeded with one session of standard volume Plex. And at 48 hours, we could see that his bilirubin levels had decreased significantly. He had a good clinical response. Direct bilirubin came down to 20. And at day 5, the trend was improving. The patient was discharged on tapering steroids and on oral antipruritic medications. Now here is where it gets interesting. At 1 week of follow-up, he presented to us now with severe odynophagia. He had recurrent vomiting, had low-grade fever, and now new onset renal dysfunction. Clinically, the cholestatic symptoms had become better, but they were persistent, so we readmitted this patient. So here are the workup on day 12 when he was readmitted. We could see that the bilirubin levels had improved further, but now SGOT-PT had increased, alk-phos had also increased, and there was a new onset renal dysfunction. Creat had gone up to 1.9. So what should we suspect now with a new onset fever, odynophagia, worsening of enzyme levels, and a new onset AKI? Dr. Rahul?
I think with the fever now, this patient is also having rising AST and ALT and AKI, and odynophagia is also there. So the suspicion would be because he was on steroid, there can be some kind of infection which is affecting ulcerations over the mouth. And other thing which I can think of can be drug-induced liver injury also, because some of these patients might be taking some antibiotics or some CAMs as well. So I think these two things comes into my mind: infection and a drug-induced liver injury.
Right. CMV infection, herpes, CMV, and drug. These will be people.
Yes, sir. So clinically also, he had oral herpes labialis. Because of odynophagia, we did an endoscopy. We found herpetic ulcers in the esophagus. So as rightly pointed out, there can be steroid-induced immunosuppression leading to reactivation. The raised enzymes can be either drug-induced or due to infection, and AKI is obviously pre-renal. So now, what do we do for the medical management of the systemic herpes in a background of underlying injured liver and with a renal dysfunction? What would be the choice of drugs, Dr. Shubham?
So, given the fact that he has systemic herpes, so systemic therapy in the form of acyclovir will be required. Oral therapy can be given in this patient. The only concern is the patient has AKI which appears to be pre-renal. So that needs to be taken care of by IV fluids, and initial dose of acyclovir must be given in renal modified form by calculating the eGFR. Further which, once the AKI improves, we can change the dose of acyclovir.
So you're very right, we have to avoid acyclovir or do a renal modified dose because of the risk of crystalloid nephropathy. So we started him on valcyclovir, and now the next question is, what will be the role of steroids in this situation? Now, whether they are beneficial or contraindicated? Dr. Abhishek?
I think with the addition of superadded infection, definitely we have to stop steroids, and they are contraindicated in such a scenario, and we have to treat the infection and give him hydration for the AKI.
But why think that it should be beneficial now? We have already burnt our fingers. No, but why this question at all?
Sorry, sir, I didn't get what you said.
Sir was asking that why is this question being asked? We already know that we have burned our hands with corticosteroids.
Yeah, so we only have two indications of corticosteroids in herpes simplex, either keratitis or encephalitis, so steroids were stopped. Now the last question here is, did Plex increase the risk of secondary herpes, Dr. Arka?
May or may not have. Obviously, Plex will not only take out anti-inflammatory, pro-inflammatory, takes out all your things, so it ultimately does immunosuppress the patient. And I mean, viral reactivations, if you really look at the literature, I think 1 to 2% of patients post-Plex can have it. Post-Plex infections, 10% of all post-Plex infections are actually viral reactivations. But my point really is that when we do Plex for ALF or ACLF, I think we see a lot more infections. Those patients are much more critically ill, immunosuppressed. But when we're doing Plex for AVH with prolonged cholestasis, there I think in our experience, the rate of infections is actually pretty low. And this patient was also on steroids. So whether the herpes has been precipitated by steroids or more likely to be due to steroids, in my opinion.
So true. In 2023, a large multi-center trial which did Plex for other indications, not for cholestatic jaundice, but in 711 sessions they found 14 viral reactivations, that's approximately 2%. So there are multiple confounding factors here, but yes, we need to know that Plex does induce the risk of viral reactivation. So now we followed up this patient, antivirals had been started, steroids were stopped, supportive treatment was continued, and by day 18 his bilirubin trend was better, OTPT had started decreasing, his renal dysfunction was better, he was discharged. At day 28 the things were looking much better, bilirubin had gone down to less than 10, SGOTPT levels were almost near normal, and he was doing fine, and he had a complete recovery by 8 weeks. So we have few take home points here. Prolonged cholestatic jaundice is rare, but it is a real entity. Steroids have a definite role in a short-term use. Pruritus management can be challenging, where medical management overscores the role of Plex. And Plex can induce immunosuppression-induced secondary infections. And therapy optimization and modification has to be a case-based approach. So, thank you, and I bring you all greetings from AGI. And my regards to all the organizers for having such a brilliant conference, and it has been an academic feast for all of us. Thank you so much.
I think we can have a few questions and answers for Dr. Arora's session and the case discussion in the house.
Dr. Arora, can I ask you? Dr. Anil, I'm here. You know, for hepatitis B treatment, CHB, there are guidelines which say that you have to have a HBV DNA level. For E antigen positive and for E negative, you should have 2,000, and for E positive, 20,000. In patients with NAFLD or MSLD with CHB, would you change this guideline for starting therapy? You think these are patients which would require earlier treatment, or would it be the same?
I believe that anybody who has a competing pathology over and above the baseline HBV, we should be more liberal. This, cutoff of 2,000, there are, we in fact are publishing our own very liberal guidelines. WHO is very liberal guidelines. China is liberal guidelines. So this cutoff of 2,000, if it is good, then why 1,800 is bad? There is no scientific basis for that. How is 1,900 bad? So we have to be more liberal with this. I agree with you. Any competing pathology, but if you are alcoholic, you have a metabolic syndrome, or you have concomitant hepatitis B and C, my threshold for starting, which is low in any case, will further plummet down.
But you also said patients with NAFLD have a milder disease when they have chronic hepatitis.
As I said, this is only the data which if you look at the mechanistic interaction, if you have fat in the liver and NASH, it will try to clear the virus, but it does not translate. Same inflammation which is decreasing the HBV is also propagating fibrosis. At what matters at the end of the day is injury to the liver, whether it is because of B or NAFLD, it doesn't matter.
That's true, absolutely right. You know, they have lower levels of HBV, DNA in NAFLD, but they probably have a more severe disease.
Because
So it
by
should be treated
increasing the
early.
immune system, you may be clearing the virus, but at the same time progressing the injury to the liver by increasing TLRs and stimulation of and activation of the hepatic stellate cells and TNF alpha induced changes.
Questions from the house?
Sir, what would be the choice of antiviral in such cases?
Yeah, I'll
with
still
fatty
stick,
liver.
since there is so much of controversy in management, my drug of choice in, I think all across the world now is TAF. It is at 1/12 the dose of the conventional drug. It is safe, hardly has any resistance. Just based on few studies which show dyslipidemia because of the TAF, the learning lesson for me and take away point for me will be, I'll be more concerned about monitoring their lipid parameters. I'll not change my practice of shifting over to TDO. I'll still prefer TAF.
Can I go with the question? Dr. Arora, thank you for an excellent talk, sir. I just wanted to ask you, if you have a coexistence of HBV and NAFLD, you did speak about it, about HCC a little. Would your screening strategy or frequency of screening change a little? Because I think that we have stuck even to hepatitis B to the routine screening with alpha-fetoprotein and ultrasound. In MASLD, we are now talking about picking them up early, because once you pick them up late, it's very difficult to actually go with curative treatment. Then we speak about abbreviated MRI and everything to be quicker. So, any change in your mind?
Yeah, I agree. You know, these are two surprises. I'm happy, first of all, Neeraj thought of this, topic as a something which needs to be discussed, because both these etiologies are known to cause HCC in the absence of the cirrhosis. So, in presence of cirrhosis, it is understandable. You have hepatitis C, you have alcoholic liver disease, you have cirrhosis of the liver. But both hepatitis B and NAFLD can cause cirrhosis in the absence, can cause HCC in the absence of the cirrhosis. So, what will be the effect of compound etiologies? If you look at the various studies which I have shown you, the odds ratio has varied from 0.2 to 2. That means the risk is down by 80% to risk is increased by almost double. So I don't know what to believe. But I fully agree with you that at the moment the strategies for screening of HCC are pretty dismal. Something needs to be done, whether it is molecular biology or blood screening, something additional need to be done. I think abbreviated MRI is one of the good advances which need to be, most of us are starting to see its utility in near future.
The second thing is the case presented by Ashish. At one point of time, he asked the audience a question whether you will consider liver transplant or not in these patients. And I think the audience answered probably no. And based upon a procalcitonin level or based upon presence of infection.
I agree. I would have considered this.
You have to consider
absolutely.
in these patients. And in fact, we have to go one step beyond that also.
Yeah.
I think. Suppose you don't have a living donor. I think in today's scenario in India, you probably should even list this patient for a DDIT if at that point. Because if you lose that opportunity, we were lucky that, I know we did plasmapheresis, whatever, but so many of these patients with HIV, you are losing today, trying to just go on medical treatment and giving away the thing of transplanting them. So I think that's one thought we should have in our mind.
I'll fully agree with you. I'll still go a step ahead of you. You see, if you look at the ASLD guideline, anybody with acute viral hepatitis, INR more than 1.5 and encephalopathy should be counseled for liver transplantation. There is no question. Now the next 24 to 48 hours are pretty dynamic. You never know. If he survives, well and good. If it doesn't, then if you do not counsel, especially for LDLT setting, I think you're not doing a good job. I fully agree with you.
Sir, opinion of entire panel, sir, because what the case was presented that steroids were given for a prolonged cholestasis, I think it should not be given because it's a self-limiting condition. And steroids, there is no strong data for steroids also, and it will, in our Indian setting, it will cause more harm as it caused rather than benefit.
But these are clinical situations. Most of the patients with severe cholestasis and acute viral hepatitis, which tends to occur in 5 to 10% of the patients, they are very miserable. They cannot sleep because of the itching. Or these steroids are anti-inflammatory drugs. It is only in subgroup of the patient who do not have hepatitis B and C, who have hepatitis A, which is a self-limiting illness. For a short period of time, most of us have good results. So this being anti-inflammatory drug, it decreases the edema and decreases the cholestasis. So short term is justified. And we give it only when you are pushed to the wall. You will admit, try to see if the patient is uncomfortable increasing bilirubin in the absence of hepatitis B and C. This case was hepatitis A. I think we were justified.
I just wanted to also check out about, do you think serum bile acid levels should be done as a test to monitor the response? It could be like people who may be responding to the steroid or to UDCA or to whatever you're using. But
only clinical scenario in which you need to monitor is something called intrahepatic cholestasis of pregnancy. Short of that, whether you do it or not, will go both by clinical assessment. If the patient is okay, bilirubin, bile salts are say about 120, it doesn't matter. We do not routinely check it, other than when you end up terminating the pregnancy and saying.
That's why, would it be of use in viral hepatitis A with cholestasis? Would you think we can have a guideline according to that?
But see, you will go more by symptoms. If it is high, and how would you recommend in the absence of the symptoms? And even if there are symptoms, as Dr. Chawla very rightly said, most of us will only admit the patient, do a liver biopsy, be sure that you are not trying to miss out something which could be the cause for other causes of cholestasis. So we do everything. We ensure hepatitis B and C is not there. We know it is a self-limiting A and E, and we have done a liver biopsy. Only then we give steroids for a short period of time. That is justified.
But Dr. Arora, is it not so that the levels of bile acids are not, they do not correlate with the symptoms, itching and all that? So why to get the bile acid level done? That's one question.
We don't get it done. Other than, we have a reason in intrahepatic cholestasis of pregnancy. Over there, short of that in clinical scenarios, none of us is getting it. What he was proposing is, do we need to do it?
And my question, Dr. Ashish, if sertraline is to be given for itching, I'm not sure how long. In any case, not regarding that.
So for cholestasis, if there is prolonged itching, we can give it, helps in soothing the...
it has to be for months together or...
pruritus to patient feel better with the pruritus, sertraline can be given for short duration. To answer the bile acid question, so sir, we have done the study in CMC Vellore in which we have compared the delta decrease in the bile acid and bilirubin level in the patient with the drug-induced pruritus cholestasis. So we didn't find any change or correlation between the bile acid or bilirubin. So there's no point of measuring the bile acid with the patient.
So I think we need to end. Thank you all the experts and speakers. We would like to request you to assemble at the left side of the stage for the photo. And we would like to invite Dr. Neeraj Saraf for the vote of thanks.
I would like to thank 4 sets of people. And I'll just take 2 minutes because I know it's getting late for lunch. So I'd like to thank all the faculty who has joined us and given excellent lectures, contributed to excellent discussions. Special thanks to Sherry and Mark from coming all the way from Italy and Singapore to join us here. Thanks to all the delegates for joining here and making this meeting successful. I'd like to thank my team, Swapnil, Narendra, Ashish, Prashant, Dr. Soin, for making the scientific program and helping in making this meeting a success, and my residents and the other members of the team. But I think I want to have a special thanks and a round of applause for Dr. Swapnil, who has worked tremendously hard throughout the meeting, and you could see him yesterday and today also on the move all the time. I would like to thank my providee for doing a wonderful job of organizing this meeting. Special thanks to Pranav, Shilpa and Shipra. I know there are a lot of people, but I'm only taking 3 names right now. And last but not the least, the pharma industry for all their support, financial support and logistic support for being our academic partners. Thank you, and please join us for lunch.